welcome you all from Amman in this great scientific activity entitled Advancement in Keratoconus Management. First, I want to thank our speakers for accepting the invitation to participate and to share their experiences, as they are not only experienced in this field, but they are the world pioneer in this field. Also, I want to thank the Jordan Ophthalmological Society and the Middle East Eye Hospital, which is a state-of-the-art new hospital here in Amman, Jordan, founded by our great phaco surgeon, Dr. Musa Baydoun. A big thank goes to Elsa Institute and especially to Nikki for her great efforts in bringing this into life. And thanks Medicals International for their support and commitment to medical education. Finally, I want to thank all the attendees from all over the world. And I want to say that this activity is granted a 1.5 hour of CPD by the Jordan Medical Council. I will give a short introduction for each of the speaker. Our first speaker is Dr. Professor Dan Reinstein. He is from London. He is a dedicated laser eye surgeon with an international reputation as a uniquely experienced and pioneering LASIK surgeon. He's one of the first doctors that discovered and started the use of ultrasound to scan the epithelium 20 years ago. And now the epithelium is one of the most, if not is the most sensitive diagnostic tool in keratoconus. His talk will be about the diagnostic imaging of keratoconus. Next, we'll have the great Dr. Farhad Hafizi. He is an innovative corneal surgeon and a researcher dedicated to advancing the field of corneal cross-linking for the treatment of keratoconus and corneal infections. Professor Farhad Hafizi works clinically at the Elsa Institute in Zurich, Switzerland. His talk will be about the sub-400 protocol for the ultra-thin cornea. Then I will have my short talk about when and how to cross-link. Then our great friend Miguel Riquiqui, he is an anterior segment and a refractive surgeon and a researcher, a pioneer in the field of cross-linking with many publications and innovation in the field. He's always supporting us with his excellent talks. He will be talking about his unique approach, surface ablation and keratoconus. Next, our great speaker from Egypt, Dr. Muhammad Shafiq Shaheen, a professor of ophthalmology, a cornea and a refractive surgery consultant at the University of Alexandria. He has a very impressive history in the field of ophthalmology with more than 60 original publications, including book chapters. He is a member of many international refractive societies and the funding of many others. He will be talking about refractive surgery after cross-linking. Next, our Dr. Ala al-Daynasouri, a very well-known figure in cornea and refractive surgery also, not only in our region, but all over the world. And he was among the first refractive surgeons to perform excimer laser surgery. And he was the first to introduce many ophthalmic procedures in the Middle East. His talk will be about phakic cleansings in keratoconus. And last but not least, our great friend and teacher, Dr. Samer Hamada, a consultant ophthalmic surgeon and pediatric ophthalmology, specialized in corneal pediatric cornea at Queen's Victoria Hospital in London. He will be talking about how to avoid pediatric keratoplasty. So I'm done now. Please, Dan, if you start your talk, the platform is yours. Thank you all. I will mute myself and please.
Thank you very much. Let me just get my screen sharing going properly here. Okay. There we go. Okay, so I assume you can hear me and you can see me. Yes? Is everything set up right?
Yes, it's clear. Your voice is clear.
Okay, thank you very much. Okay, very good. So, well, you know, I thank you for asking me to speak about the subject. I mean, you're all experts at this, and in fact, the expertise in this area has grown exponentially in the last 25 years. I will start this talk by saying that, of course, I have a financial interest in the ultrasound technology that led me to understand epithelial mapping, which had never been done before. I did it in 1991, and it was completely ignored for many years. And then finally, when I started applying it to screening for keratoconus, it started getting attention. And it led to a whole industry now of OCT machines measuring epithelium. But I remember, and this is, you know, you say, I remember how old I am. I remember when I was sitting in an ISRS meeting. It must have been 1992 or 93. And I remember one of our great mentors of all of ours standing up and saying, it is not necessary. Maybe it was 94 actually, because it was around the time of the approval of PRK. And I was told, and we were told, it is not necessary to do keratoconus screening for PRK. And that was the opinion, because there was a debate as to whether it was really necessary, because it didn't matter if you did PRK on top of keratoconus. And many people still do it, even without cross-linking. I think this is a funny slide, because what this is saying is that, you know, sometimes the details that you don't see are the details which can lead you to a wrong diagnosis and a wrong treatment. And that's basically what this is talking about. This is a summary of the pre-op assessment that a patient will get in my clinic. Every single patient gets in my clinic. And the testing only takes 1.5 hours of man time. And then, of course, with the discussion and the consent information and all that, the patient spends 3 hours between 2 visits before the day that we actually do surgery. So, you know, diagnosing keratoconus involves the history and, you know, the manifest refraction history and the history of the cylinder and all of these things that you want to do. Today, we're just going to talk about machine diagnosis of keratoconus. And I'm not going to talk at all about the excellent work that the brain organization in Brazil, led by Renato Ambrosio, they're doing phenomenal biomechanical work and linking that to shape. I'm going to talk about shape and anatomy. So obviously we want to detect keratoconus before refractive surgery. This is a keratoconus symposium. And I would say that in this instance, what's most important is 2 things. We want to detect keratoconus as early as possible, because when you catch this disease early, you can prevent someone from possibly ever having consequences of having the disease by first telling them not to rub their eye, but, you know, by cross-linking them in advance of any loss of best spectacle corrected vision. And that means that diagnosing keratoconus before the topography, it makes it obvious, would be an advantage. And the second thing I'm going to go for at the end is how diagnostics can be used to actually monitor the effect of your cross-linking, or whatever procedure, rings, or whatever procedure you've done in the cornea, because monitoring it by topography is not the most sensitive way of monitoring the effect, for example, of cross-linking. So I'm going to finish with that. Okay, so let's get to the meat here. Big old days, we were talking about looking at Munson sign and scissoring on the reflex of the cornea, and the astigmatism shifting from with the rule to against the rule. And that was sort of like the clinical diagnosis of keratoconus. And, you know, by the time someone has Vogt stria, I mean, if you don't have a topographer, I suppose you can start looking at these things. But these things are now kind of irrelevant to the diagnosis of keratoconus early on, because what we're looking for is early detection in order to help people before this sort of stage occurs. And like I said, the early days of topography was, you know, cluttered with everyone and their grandmother giving different classifications of the different shapes of everything, and which ones were more likely to be keratoconus and which ones were not. And obviously the ones in red are the ones that are more likely to be keratoconic, although butterfly actually more associated with PMD than keratoconus, which is a Venn diagram disease, but there is some cross there. It was really in 96, the first orb scan came out. I was doing my fellowship in the clinic where they had an orb scan 1, very poor reproducibility machine, but it was the first time we were looking at the back surface, and we saw that we could get changes on the back surface before they appeared on the front surface. And you know, here's an example of that on a more modern machine, 10 years older, a Pentacam, where the front surface really does look relatively normal. But there's a saddle appearance on the back surface, but not on the front. not in that way. And here's the other eye, of course, where there is slightly more asymmetric astigmatism, but the back surface is much more weird than the front surface. So early changes of the back surface became the next most sensitive way of detecting keratoconus. And we're not talking about late cases here. Late cases is obvious because late, the front surface is going to show the keratoconus. So you don't need a back surface if the front surface is already diagnostic of keratoconus. But your front surface might be a false positive of keratoconus, as we'll show in a minute. So the coincidence of all these points, the steepest point of the front, the steepest point of the elevation of the front and back, and the thinnest point of the cornea, the coincidence of those points is what used to be our qualitative way of saying, oh, this is keratoconus. Now, Bellin came up with this smart idea. He said, well, we're trying to find a cone inside an asphere, which is an toric ellipsoid. He said the way to exaggerate these elevation maps, which are giving us a lot of false negatives, is to fit the best fit sphere of that back surface and then subtract the central 4 millimeters around the apex of that of the back surface. Subtract that and fit another best fit sphere. Now, this is what Orbscan was doing. And this is what the Bellin did. Now, what the Bellin did was it said, look, exclude the area where the back surface has an apex and fit the rest of the cornea and see if there's a localized ectasia. It's very clever. And later, with this color coding, and later it was Ambrosio who did some mathematics on this and said, well, we can look at the thickness distribution, the spatial radial averaging, and we can, depending on the slope of this thing, we can write some characteristics of the thickness, of the curvature, of the distance of the thinnest point from the center, and all of these different parameters. And we can do all these different T, B, P, and T, all these different parameters in A, and have a big D. And the big D combined tells you the relative risk that this is actually keratoconus. So this became the Bellin-Ambrosio display, and I think since the mid-2000s, everyone has been very reliant on this. Now, of course, we all know we've got cases where the Bellin-Ambrosio, the D lights up as yellow or red, and we're convinced that it's not keratoconus. We're convinced it's not keratoconus, and we send the case to Renato, and he says, yeah, but it's a susceptibility. You shouldn't really do it, and doesn't really leave you anywhere. Okay. So moving on. We now have this, essentially, I get into trouble for saying this. I get letters of complaint, emails of complaint when I say what I'm about to say. In 2020, if you are a corneal specialist and you don't have access to epithelial mapping, which means an OCT that can resolve the epithelium and map it, or high frequency ultrasound, then you are not practicing at the standard of the time. You may be practicing at the average standard, but the standard possible is now epithelial mapping. And layered pachymetry within the cornea, I'm sorry, but it is so well studied now that it would be, I would think, indefensible if you were in court and you had been caught by missing something and you hadn't looked at the epithelial thickness, for example, in a LASIK case, pre-op that became ectatic. Defending yourself that it was pre-op keratoconus and it's not your fault would be hard if you didn't have a map of the epithelium to get you out of trouble. And like I said, the ultrasound system is how this all started in 1991. I had basically, like from 91 to 2015, no one else was measuring the epithelium as a map. So I had a long time to publish 40 papers on just the epithelium. And people, a lot of my good friends and colleagues here that we're sitting on the panel with, everyone says that Dan Reinstein, I am very superficial because I've only ever studied the epithelium. Anyway, let's go to how this works. So one of the first things that we did was to characterize the normal epithelial thickness profile. And remember, normal epithelium profile had never been characterized. It had always been published in textbooks as just being a single layer that's 50 microns thick. And we found that actually the central thickness was about 50 microns, but there was a superior and to inferior difference and a nasal to temporal difference in thickness. And this difference had mirrored asymmetry. So the nasal was thicker than the temporal. And then, of course, I had already postulated many years before, looking at complications of LASIK and PRK and why the epithelium changes, as to why the epithelium takes a new profile. And it's because of the epithelial dynamics of the outgrowth force and the ingrowth force of the semi-rigid tarsus, which you're blinking 10,000 times a day. And so that makes the template for the outer surface of the cornea. And so this outer surface of the cornea is defined by the eyelid. And that's why with age, the epithelial profile changes. And so astigmatism changes from with the rule to against the rule, because the eyelid laxity increases as we age. It all makes sense. It all is logical. So exploiting this for keratoconus started with looking at keratoconus itself. And then when we realized what the pattern was in keratoconus, we said, we have a way now of developing a tool to detect the earliest form of keratoconus before the back surface can statistically suggest that this is keratoconus. So how it works is this: you've got a normal eye, the front surface, you've got the stromal surface, and you've got the back surface. And in between here is the epithelium. So imagine the case where you have keratoconus. So the front and back surface of the stroma are sticking out, and the epithelium is thinner over the cone, and it's thicker on the sides of the cone. That's the donut shape of epithelium. Or anyway, the most important sign is what I call focal thinning. In other words, thinning where it's not supposed to be thinned in a focal way. Now, imagine that you have a situation where the keratoconus is so early that there's a back surface change and there's a front surface of the stromal change, but the epithelium is still capable of fully compensating for the anterior stromal change. So what happens there is that the topography looks totally normal, and the back surface has a little bit of asymmetric elevation. And now here's the problem. Pentacam, any orb scan, all of these devices with back surface measurements, there's a lot of noise in how they measure the back surface. And so a small deviation of the back surface gets lost in the noise. But a 1 or 2 micron change in the epithelium in a region where, 1, you don't expect it, and 2, it is coincident with where the back surface is slightly elevated, maybe a little odd. The coincidence of the back surface with the thinning of the epithelium, that is what I would call the earliest moment that you can detect keratoconus anatomically. And now I was talking about this for many years, but no one paid attention like I told you, the first 15 years of my career were very lonely, except for actually some of the people on this panel. And one day I said, well, here's something interesting. You can have a case where there's inferior steepening and the machine says this is keratoconus, but it's only because the epithelium is thicker, not because there's keratoconus. In fact, you cannot have keratoconus if the epithelium is thicker over that region of steepening. Now, there is one exception to that, but we can come to that in discussion. And when I found this, and I did a study showing that our volume of surgery at our clinic was 7% higher, because out of the 10% of patients who had suspicious topography. Those people got an Artemis scan, and those people, 84% were proven to not be keratoconus and received LASIK. So suddenly the dollar signs started to be attached to epithelial profiles. And that is when the OCT companies said, I think we need to make a product because ultrasound is a little bit inconvenient. So that's essentially the story behind epithelium. And, you know, all of our studies where we had shown that, you know, the more severe the keratoconus, the thinner the thinnest point gets, and the thicker the thickest point gets around the donut. All of those were ignored, but finally we had this way of diagnosing keratoconus or excluding keratoconus by exploiting the difference in patterns. And we wrote a model, which we got an NIH grant with Ron Silverman, who designed the Artemis with me. And, you know, Tim Archer and Marine Gobet was with my research team in London, and Raksha and was our programmer. And what we did was we did a multivariate stepwise discriminant analysis of 161 variables on epithelium that we could think of. And in the model, we managed to get a 6-variable model that had 99.2% specificity for keratoconus and 95% sensitivity for picking it up. And that is the highest sensitivity and specificity for any algorithm that has ever existed, ever. And think about it, it's because the epithelial change of 1 or 2 microns in the wrong place is incredibly suggestive because the epithelium is so stable. If the epithelium was not stable, then spectacles wouldn't work, right? If your epithelial profile was a few microns different from Monday to Wednesday, that would change your cylinder or your refraction. But your eyes are always seeing well through your glasses. And that is why we know the epithelium is absolutely stone solid and tiny changes can be very, very specific. So here's an example of a completely normal topography in a flat cornea in a hyperope with 20/12 vision. And nothing on the Bail and Ambrosia, a little yellow there, perhaps because the cornea was 477. The bad was normal, but whew, magic. A very characteristic donut shape of the epithelium, and the pattern deviation from the standard deviation for the population shows thinning where you did not expect it. It's only half a standard deviation thinner, but the pattern of thinning is what gives it away. And that 6-variable model is what's picking that up. And this particular case classified as keratoconic, like really classified it as keratoconic. And this patient didn't get surgery. You can have so basically we're talking about being able to avoid all of these false negatives, these normal topographies that actually have epithelial donuts underneath them. But what was most important for commercial reasons was to take people whose topographies were classified as positive and epithelium proved they didn't. Now, this is important for cross-linking. We have 1 or 2 patients that have left our practice and gone, and we've got news that they were cross-linked when we knew that they didn't have ectasia. They had thicker epithelium inferiorly, for example, after a hyperopic LASIK, and the epithelium gets asymmetric because the superior epithelium becomes extra thin because of the eyelid force. And they were cross-linked by this surgeon who didn't have an epithelial map and thought that this inferior steepening was keratoconus. So, you know, detecting epithelium with topography was step 1, using the back surface was step 2, and using the epithelium is the modern way of confirming or rejecting the presence of keratoconus. You can use tomography to classify the severity, but to detect it, you cannot do it as well with a shape of the front or back surface with epithelium. Now, you know, don't judge a book by its cover. Okay, so now let's just finish with the fact that it's a big picture that you're talking about here. It's not just epithelial. You're going to go and get a lot of history, you know, the ethnicity, the low CH and CRF values. I mean, all of these different things are going to come into, you know, young age. But let's talk for a second about false positives with epithelium, because I didn't say it was 100% sensitive and specific. And here's an example where you can have I don't know why this is appearing this way. This is blocking pardon me. Let me just quickly fix this so that I can make my point. Okay, there we go. So, okay, so back to here. So you've got a basic, slightly skew, but basically a normal but slightly skew anterior surface, and you've got a donut pattern on the epithelium. Oh, that's keratoconus. Oh, you see, that's keratoconus. Well, it's a false positive on the epithelium, because actually, oh, sorry, this isn't. This is a true positive. Sorry, true positive. No, false positive. Sorry, I'm getting confused here. This is not keratoconus. This is basement membrane dystrophy, which is masquerading as keratoconus by having thinner epithelium here and very thick epithelium inferiorly. And even our algorithm is reading this wrong. So here's an example of a colleague of ours who had a Bell's palsy and was recovering, but he still wasn't blinking naturally in his right eye. And I said, have you got an epithelial map? And he said, no. And I said, let me film you, get an epithelial map. Here's the right eye epithelium, and here's the left eye epithelium. And this was his refraction before the Bell's palsy. And this was the refraction after the Bell's palsy when he wasn't blinking. So as you can see, the lack of blinking caused the epithelium to become thicker and made him myopic. The Barraquer rule of thicknesses, adding tissue in the middle. This is a perfect example of how the eyelid controls the epithelial profile. Here's an example of a misdiagnosis of keratoconus and the epithelial thickness, very thick here. It looks abnormal, but of course it's because of exposure dry eye. This is totally different. This is not keratoconus. So the future is really to be able to combine front surface, back surface, and epithelium. And there is a device, now I have no financial interest in this, but I have 5 of these devices in my clinic, where each of these maps is now incorporated into one single device where it's acquired simultaneously and everything's registered because it's the same machine. And the back surface is probably the most accurate back surface of all back surfaces on the market because it's not Scheinflug. It's an anterior surface which is photographic by Placido, and a back surface which is calculated by an extremely accurate OCT. So the back surface is very accurate, which is way better than any Scheinflug for back surfaces. So in summary, you've got the evolution of the way that we have diagnosed keratoconus, combining machines, and now you have, and I believe that all the companies are going to go this way. All the companies are going to have to do the same thing because there's just no better way of doing it than this. Now I'm going to finish, because this is a keratoconus symposium, on this paper, which we published quite a few years ago. But it's interesting because we were looking at cross-linking in the early days. I did my first in 2004. And we had an ectasia patient from back then, and we were studying his epithelium over the years. And what we found was that, here was his pre-op, and he had his LASIK, and this was his refractive history, and he presented to us here with ectasia. He had surgery in South Africa, and here we go with ectasia, very, very myopic, -16 and -3, starting at -8 pre-op. Here's his keratometry, and well, we don't really have any data points, but we cross-linked him, and look what happened to his Ks. Obviously, they stabilized. He was getting steeper and steeper and steeper, and he stabilized. Steeper and steeper and steeper, stabilized. And this is stabilized over a period of years. And look at his ocular wavefront. His spherical aberration, absolutely stable. His coma, absolutely stable. Really stable in both eyes. So everything is stable optically, and everything is stable keratometrically. And I know that you're all all of you fancy cross-linking people with all your protocols, you monitor everything by keratometry and Kmax and all these things. Well, guess what, guys? Here's an example where the topography over years barely changed. The higher order aberrations, as I showed you on the graph, barely changed. But look, This is the pre-op. Here's the cone, big ass cone just being absorbed by epithelial thinning. Another one where it progressed further before we cross-linked. And now this is 6 months after cross-linking, 14 months after cross-linking, 22 months after cross-linking. And what do you see? Even though the keratometry and the topography looks quite similar, what we're seeing is that subsurface, the stroma is flattening. So the epithelium is too thin, but the epithelium is managing to thicken while the cone is going down. We're not seeing the changes on the surface because they're subsurface changes. And everybody knows that cross-linking can produce chronic flattening forever, keeps on flattening. I don't know if it's forever, but at least 5 or 10 years, we see cases that are getting flatter and flatter and flatter. And we monitor that with epithelial profiles because the topography will not give you that information. The topography is masking the actual change on the stromal surface. Here's another case where pre-op, 6 months follow-up. Look how the cone is getting smaller. The cone is getting smaller, but you can't really tell. Look at here and here. It almost looks like more severe here than here, but it's not. The cone is smaller. And so I mean, my message, I think here, and I've renamed myself Dan Epithelium Reinstein because it's about the epithelium in keratoconus. And if you want to do sensitive monitoring of what's changing, the epithelium is going to be far more sensitive and far more sensitive than any biomechanical or any keratometric or optical test that you might be doing to see whether your treatment is working or whether there's still progression. Okay, thank you very much.
Thank you, Dr. Dan, for this is very interesting and very nice presentation. Our next speaker is Dr. Farhad Hafizi. Please, Dr. Farhad, we will have discussion after Dr. Farhad talks.
My pleasure. So I will go from the epithelium to something that is bothering most of us clinically quite a lot, which is how do I cross-link corneas that do not fit the standard criteria? Specifically, how do I cross-link extremely thin corneas? These are my financial interests for this presentation. Now, if you look at cross-linking for keratoconus as it was established by Sperl and Seiler some almost 20 years ago, one element that of course makes the method so valuable is that in countries with a central registry for transplantations like Holland or the UK, the number of corneal grafts has dropped drastically since the introduction of cross-linking. But we also know that this might apply to all those who fit the technical settings of the method. But what do you do with such a case? What do you do with the keratoglobus case that has an extreme bulging and an extreme thinning? Well, in this case, this gentleman had clearly a documented progression, and he had clearly a documented progressive loss of vision. So in such a case, we can help in terms of visual rehabilitation, and even in such an extreme cornea, we were able to get the patient to an incredible 20/20 vision. I'll show you how. But what is this worth? What is this worthwhile if we cannot stabilize the disease at the same time, and at some moment the patient will need a transplant? Now, this is the most extreme case of contact lens adaptation I have seen so far, because in Switzerland we are lucky to have four companies that produce scleral lenses independently. So we are very, very spoiled in this regard. But something like this I've rarely seen. I only had 2 cases in the past few years. So this cornea was so extreme, you cannot even take normal measurements and have the molder of the scleral lens company create a first pair of lenses. No, you have to take an imprint as if you had a dentistry problem. So you take this very special imprint on a cornea that is extremely steep and thin, and you end up with contact lenses that look nothing like the regular scleral lens. They rather look like this. So this is 11 millimeters high. It's incredible. But what surprised me even more is the visual acuity the patient was able to reach. It was 20/20. Does it switch? No, for some reason I'm blocked here in my presentation. Now it's coming. So 20/20 vision. So if the patient can see that well, then we should try to stop the progressive state of the disease, even though this is far beyond anything that we would do normally. I'm not fully sure whether this is the same cornea, but this is, what I wanted to show you is an example of a cornea that is clearly thinner than 300 microns at the thinnest point. Because if we are able to cross-link corneas that are extremely advanced, we of course enlarge the spectrum of indications. Now, going back to what Salish and Spörl have established in the very beginning of cross-linking was a technical setting, a total energy, which means time times intensity, that would kill the keratocytes down to 330 microns, and we have an assumed effect of cross-linking down to that same depth. So a safety margin of 60 to 70 microns to this famous 400 micrometer number. Now on the left side, you see a microscopic section. If you plot this section, and you can nicely see how the keratocytes are missing, they're all died by apoptosis. Now if you superimpose this section over the demarcation line, you can better understand the change in reflectivity that defines the line. How to cross-link corneas thinner than 400 microns of stroma? Well, 3 different techniques emerged over the years. And there is another one I will mention in the end. The first technique that came up was our idea in Zurich on swelling the cornea. If you take a riboflavin that is hypoosmolaric, you will swell the cornea, thus you get to 400 again. The second method came a few years later by Susan Jacob, and she said, well, if I put a contact lens on the eye, I increase thickness and I can safely cross-link a thin cornea. Cosimo Mazzotta had a first idea on thin corneas back in 2014, where he said, well, I can also leave an islet of epithelium over the thinnest point. Cosimo had another idea lately, and I will mention it in the end. But looking at these 3 protocols for thin corneas, I do not perform any of them. Why? Because all of them have major disadvantages in my eyes. Let's start with our own method that was established in 2009. So it's based on osmotic pressure. And the biomechanical effect is quite good. Wollensak published yet another paper last year showing that if you swell a cornea, the biomechanics is similar to a non-swollen cornea once it has deswollen. So the biomechanics is not the issue. What the issue is it's not very predictable. So you can see here, one cornea swells 30 microns, the other swells 100. So you never know what you will encounter once you start the procedure. That's as much as it goes for the swelling. Susan Jacob's method is not a good solution in my eyes either. Why? Because by placing a contact lens onto the cornea, you run into a major problem of oxygen diffusion. We have already published 5 years ago that the biomechanical stiffness increase is 30% diminished as opposed to epi-off cross-linking. So if you put a contact lens on the cornea, you have 30% less biomechanical effect. And again, Wollensak has done the same thing last year, same number, 30% less effect. Now the last method, Cosimo Mazzotta's epithelium island method, I do not do either, because if you leave epithelium over these areas, you have a different attenuation of UV beams, and you have a on and off pattern of haze afterwards, which doesn't make too much sense either in terms of wound healing. What we came up with is a completely different approach. We do not look at thickness anymore, because what you've seen right before, all these 3 methods, swelling, contact lens, or epithelium island, they all try to modify thickness. In my eyes, this does not make too much sense. It was the way to go 12 years ago because we didn't know too much about riboflavin diffusion, about oxygenase factor, and so on. The second way we could have gone would have been modifying riboflavin concentration. We use 0.1% riboflavin, right? If you had an 0.2% riboflavin solution, you would have more riboflavin in the superficial layers. So the light hits more molecules and induces more crosslinks superficially before it goes down. In other words, if you go up with the riboflavin concentration, then you can stay more shallow. Clinically, not a good idea. Imagine having an arsenal of 15 different riboflavin concentrations, just like your consignment stock for your IOLs simply is not feasible clinically. What makes most sense is adapting the energy, because this can be done in a very simple way. So if you have a 400 micron cornea, why don't you crosslink down to 330, let's say with the Dresden protocol, the way we've always been doing it. But if you face a thinner cornea, then you run into trouble. And until now, we somehow modified thickness with whatever method. And this is the slide I was looking for. I described it. As I said, in the early days, we used thickness modification. We could have used modification of riboflavin concentration, which works, but it is bothersome clinically. Or we change the fluence. Keep it simple. Change the fluence. So what we have done is we found a way to modify the fluence. So whatever cornea you encounter, you always stay 60 to 70 microns in front of the endothelium. So you're safe. But you have to adapt your total fluence. The algorithm that goes with it, we decided not to protect. We made it public knowledge by publishing it 3 years ago. And based on this algorithm, we immediately started a prospective clinical trial at the Elsa Institute in Zurich. And we now have 47 years with a 1-year follow-up. And the thinnest cornea was 214 microns of stroma. I've never seen a cornea thinner than that being cross-linked. So anything below 400 of stroma, we integrated into this study. And the protocol was standardized, and that's the beauty of it. No more 10 different riboflavin solutions and approaches. No, you always do the same thing. You have a thickness map pre-op, then you go into the OR and remove the epithelium. And this is where I measure with an ultrasound pachymetry for the first time. I always have a printout of my pachymetry map, so I know more or less where to look. And believe me, with the years, you get quite precise in finding the thinnest point. And then you have a first measurement. Then comes the riboflavin, the soaking, which of course changes thickness in a certain range. This is why we remeasure thickness with the ultrasound every 5 minutes until the end of the soaking time. And this very last measurement, right before the UV light is switched on, that's the important one, because it gives you your final thickness. And as soon as our nomogram is published, you will have a table where you can see, oh, my thickness is 280 microns. And this is why I need to use these many minutes at 3 or these many minutes at 9 milliwatts to have a demarcation line that stops 60 to 70 microns before my endothelium. This is what we've been doing. The changes in the front surface were more or less what we have seen in all these earlier cross-linking studies, but what I was quite surprised to see was the high success rate. I did not expect an almost 90% success rate. This is still a little lower than the standard thickness epi-off, but again, these are corneas between 214 and 400 micron. I would have been happy with a 75% success rate, because until now, you couldn't do anything in these ultra-thin corneas. But it is what it is, and we are happy to see this number really relatively high. And what we also try to do is democratize access to this technology. So by using 3 milliwatts for large parts of the nomogram and 9 milliwatts in a small subset, but you can do the entire thing, the entire nomogram with 3, we open up ultra-thin corneal treatments to any technology existing since the beginning of time. You can have a 15-year-old machine and use that nomogram. If you want to make your life easier, then you can use Imagin's CI device that has just come onto the market, because starting autumn, it will have the full sub 400 protocol integrated. So you don't have to think. You can think about applying the right combination. You just enter the thickness and the machine will calculate the rest. Now this is the sub 400. My friend Cosimo Mazzotta has recently published another protocol for thin corneas called the M protocol. And this is from his paper. Now, where's the difference? This is a protocol also for very thin corneas. Well, basically, the difference is easy to explain. What Cosimo has done, just look at this cross-section of a cornea. Cosimo has gathered all the solid published data from the past decade, all these different protocols, and has put them into one comprehensive table, knowing that there is published data. If you cross-link with 9 milliwatts in continuous light, you will end up with a demarcation line at 300. But if you go to 30 milliwatts continuous light, you end up at 250. If you start using iontophoresis-assisted pulse light with the 10 milliwatt protocol, you go more shallow, and so on. So basically, it's a compilation of everything that was known so far. And then you can choose the protocol depending on how deep you want to go. We have done the opposite. We have one single protocol, and we have established an algorithm that calculates the total fluence. Why I think our technique is more simple to use is simply, if you have a machine that can do everything from 3 to 30 milliwatts continued and pulsed, you have the free choice. You can use both protocols. But if you have an old machine that does 3 milliwatts of continuous light or 9 milliwatts of continuous light, and not all these other more fancy approaches like iontophoresis, pulse light, then you're better off with the sub 400, because this is all you need. So we believe that the future of thin corneas is what we call individualized cross-linking. Treatments down to 200 micrometer will be possible as soon as the nomogram is published. And democratizing access, treatment can be performed with all CXL technology. Thank you for your attention.
Thank you, Dr. Farhat, for this is a very impressive talk. We will have 10 minutes discussion now. If any of the panelists, please want to ask any question, please unmute themselves, or we can take the questions from the attendees.
Can I start, Khalid?
Yes, please.
Yeah. Actually, I have a question, and I think the floor asked the same question to Dan. Dan, great talk as usual. To be honest, I believed you a long time ago, and that's when I started my job as a consultant. The first thing I asked the management, I need OCT with epithelial mapping. So thank you. Right. So yeah. So the question I think people asking here is, are there different epithelial mapping sensitivity among different OCT devices? Yeah. Like, I know we don't want to recommend brands, but what's your criteria basically? Mm-hmm. And could you just add something about measuring total cornea thickness, difference between like pentacam and OCTs? Because I think majority of people in the Middle East still relying on the pentacam to measure the thickness. Thank you.
Yeah. Well, thank you. That's kind of like a big package there. But so let me put the machines up while we're talking here. Where are they? They're there. So look. First of all, we have to distinguish between accuracy and repeatability. So, for example, if you have a pentacam and you're doing keratoconus work, you may want to know whether the corneal, for example, after cross-linking, we know that the stroma thickens, right? We know that. So you want to monitor this. If you're doing it with the same device, it doesn't matter whether it's accurate or not, right? It's just it's the difference maps that you really need to be looking at. I really think that Scheimpflug is over in terms of technology. If you look at the mathematics required to calculate the position of the back surface, it's like trying to guess the length of a stick in water. You have to know the refractive index of the stroma, and because we don't know the refractive index of the stroma, we only estimate it, or we use averages, and even the refractive index changes from front to back of the stroma. The back surface is never going to be that accurate when you're using white light and then looking for an edge and then trying to calculate where that edge has come from. The difference with OCT is that the individual A scan inside the OCT, this B scan is a lot of A scans, right, put together. Each A scan is an instantaneous measurement, and the accuracy of that thickness is extremely high. And so finding where the back surface is from an OCT that is hanging off a Placido photographic surface, which is acquired instantaneously, of course, as I said, this is actually the most accurate back surface you can get. So if you're looking at accuracy in terms of corneal thickness, OCT is going to be far more accurate. Obviously, ultrasound is going to be, the most accurate because it has the least variables on thickness. But ultrasound doesn't give you the tomography. And so in our practice, for example, we have four testing rooms because we have to do tons of testing because we test all our patients over and over again at every visit. And any of you who visited, you see that most people would have one room with lots of machines, and we have the same thing quadrupled. But I have my own MS-39 on my own slit lamp. So instead of the keratometer, I have an MS-39, and I switch the thing over and I do my own MS-39, and I use it as a slit lamp. I use it as the slit lamp of the 21st century because I'm able to do OCTs at my desk and measure things and look at quality of backscatter. So to answer your question, what machine? Look, it's not like I can prefer one machine. There is only one machine on the market that does all of the topography functions, all of the tomography functions, and epithelial mapping and everything registered. Right now, there is only one machine that does that. I presume that Heidelberg, who haven't come out with their map yet, Zeiss have not linked this to any topography yet. And obviously, these are all great OCT machines, but they're not linked to tomography.
Can I ask a question, please?
Of course.
Yeah, Dan, congratulations for your excellent work with the epithelium, and actually you've enlightened our way to a better understanding of the cornea. And of course, that the irregular cornea's problem is the epithelium masking effect. How are we far or near from having an accurate stromal mapping? I mean, to take the epithelium off and then to decide to design our ablation on the stroma. So when the epithelium comes back after a PRK, it will find a better stromal quality. Of course, that our biggest enemy is the masking of the epithelium of our irregular cornea that hides a lot behind it. So how far we are from having this?
Well,
the same question I want to ask also.
Oh, good. Well, again, while I'm talking here, I'm going to flash up some slides because I think it's always helpful to have visuals. Okay, where are we? It's not here. Okay, I thought it was here. I'll answer the question in two ways. The first is that I published a paper where we subtracted the epithelium from the anterior surface of an ORB scan, and we calculated the ablation profile, and we used the TopoLink of the Bausch & Lomb 217C in the year 2000, and we treated a patient with a short flap and a bump nasal. And she got better, and we published her 13 years later. I found her by Facebook, and we got 13 years post-op data and published her as a case report. To answer your question, the MS-39 should, if it's not in the next release of their software, very soon be providing those maps for you. because it can provide a stromal thickness map. So it's only a question that they haven't actually programmed in it. So if you get an MS-39, I have no doubt that I have no financial interest in the MS-39, but I'm just saying that machine within seconds, they can produce that map. Now, what you touched on there is really, which is great. You're obviously, I think you were trying to get me to show these slides, so thank you. But this is the project that I started about 5 years ago. I got a big grant, to spend on some theoretical physicists and engineers to help me with this. So what we're doing now is precisely what you've suggested there. So we have an epithelial thickness profile, and we have a topography. The topography looks very nice, but it has a terribly irregular epithelium around it, right? This is a post-arcade with lots of incisions and trapezoid incisions. And what we're doing, of course, as I just said, is we feed these in, and it produces the stromal elevation map, exactly as you said. So you're right on there. Now, once we have the stromal elevation map, we actually can determine how that stromal elevation is going to change if we do a trans-epithelial PTK. So many of you keratoconus experts, you do trans-epithelial PTK to lob off some of the cone, and then you're cross-linking or you remove your epithelium. Well, in refractive surgery repair, we use that technique a lot. And because of the breakthrough pattern, if you like, there's two cones here, two things sticking up. We're going to get tissue removed from two places. And based on the pattern of stromal removal, because of the irregular epithelial pattern in the transepithelial PTK, that is a shape. And knowing that shape, we can calculate the predicted refractive change of that transepithelial PTK. Once we've determined that, we know what the new stromal surface is going to look like after we've transepithelially removed the epithelium and taken off some stroma. Once we've got that new stromal surface, we now can use this algorithm, which Hartmut Vogelsang and I are developing, to predict what the epithelium will do on this new surface afterwards. What will be the epithelial modeling? And this was the epithelial modeling of this eye after the trans-PTK. And then we will know in advance what the new refraction will be refractively. And I'm calling this at the moment optical PTK, because we're doing a PTK not with the intention of changing the refraction, but at least with the knowledge of what's going to happen to the refraction. And obviously, in many cases, it's going to reduce the cylinder. It's going to reduce the coma. So you've asked a great question, and this project is underway, and we have a clinical trial now, which is prospective, and it's been approved for just before we close the doors. Literally the day before I received this letter approving the ethical approval to do this trial. So we're recruiting patients now for treatment in this trial.
Congratulations.
Thank you.
I think we are a little bit late, but very quick questions from the attendees. Dr. Dan, do you have a cut of two questions, the same questions, cut edge for the epithelial keratoconus cornea, the cut off map?
For what, sorry? For
keratoconus, to diagnose keratoconus, there is a cutoff in the epithelial thickness below which you consider.
No, I don't. No, I believe in normal distributions. Yeah. So if a cornea is 455 microns thick, it's very thin compared to normal. But if it doesn't have keratoconus, because the epithelium is completely normal and the topography is completely normal and the mechanics are completely normal, that's a normal cornea. If that was a -1, I would make an 80 micron flap with the Visumax and I would do the -1 correction, or I do SMILE. I don't believe in, you see, I believe that thickness as a cutoff was an antiquated, indirect way of avoiding operating on a keratoconic cornea when we had poor sensitivity for picking it up. So for example, that editorial in JCRS that came out saying no LASIK under 500, I was laughing when that came out, because that was absurd to say that 20% of all humans can't have LASIK, right? That's one standard deviation away from the mean. So just looking at thickness for cutoff, I think is not the point. The point is looking at if there is keratoconus. Now, is anybody going to talk about genetic testing for keratoconus during this symposium?
No.
Okay. I mean, imagine that we had a blood test or a saliva test or some test that said, yep, that's keratoconus, or that is not keratoconus. Fantastic. That's all we need. It doesn't matter what the corneal thickness is. I have one question for Farhad, if that was the last question. Farhad, I really like that idea. I love that idea that you just presented. So there's a couple of things that occurred to me while you were. One was when we do pachymetry with a handheld pachymeter, it's kind of random where you land. It's close, but you know, whatever. And you look for the thinnest point and you do 10. But you know, the sterilization of the tip and all of that stuff. You know, you can non-contact with your OCT. You would have a map and you would instantly be able to measure where the thinnest point is, which I think is what you're most interested in. And then you would actually automate the process by somehow exporting you could almost export the data, or, well, I mean, you can just put the one number in. I mean, to me, that would be just like magic, you know, to take the epithelium off, swell it a bit or whatever, and then put them in the machine, go, okay, that's the thickness, put that into. The other thing that I want to beg you for is because your device looks like actually one of the most important developments in keratoconus in the history of keratoconus, because not only are you using deep science of cross-linking, but you've made it affordable and easy to use. And you know, I mean, honestly, accessibility, like you can take that to a village in northern India and help lots of people. You know, it's quite different from the whole setup that you'd be required. So here's what I would say. If you could have that on a slit lamp with 2 stands and double and a PD adjustment, and you could bilaterally cross-link people, please. I mean, the agony of having to cross-link someone twice, you know, especially the second eye, they're ready for it. They're ready for the pain. They're ready for the, you know.
I think Farhad working on a machine cross-link 2 patients at the same time.
There you go, 4 eyes at once. Yeah.
No,
boom, 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 boom.
Now, thanks for the comments then. Well, on one hand, regarding the accuracy of ultrasound, if we have someday a machine that gives us after the epithelium is gone and scraped off, gives us reliable measurements other than ultrasound, fantastic. But remember how it was when you started to do a capsulorhexis with the needle or with you were thinking, this is impossible. How can a human being do this? But doing an ultrasound measurement in a repetitive manner and in a reproducible manner, once you've done the first 10, 20, it's relatively okay to do.
I agree.
But of course, there's always room for
sterility. I'm just concerned about sterility. Is that, you know, that's the question, sterility on the tip.
Well, but I haven't seen a single case of infection, knock on wood, in almost 10 years now. And I've been doing ultrasound 4 times in 20 minutes during the last 10 years. So we always measure, because otherwise we don't know where we stand. By the way, I hope this doesn't imply that you never measure thickness with the ultrasound, because otherwise you do not know where you are when you cross-link.
Right.
But because the UV light kills all the bugs on the surface, we are relatively we are relatively fine with that.
Okay.
So
how do you sterilize the tip?
Very gently, and to be honest, we do not sterilize them all the time and in an aggressive manner. And again, I've clinically never seen a
alcohol wipe. Or an alcohol wipe, and then you just leave it without touching anything between measurements.
Exactly, and that's all we do.
Yeah, but of course the UV sterilizes. So yeah,
exactly. The UV, it's a puck cross-linking you do at the same time.
Sorry,
Farhad, can I ask? Have you measured in your paper? Great work, actually. Have you measured the corneal thickness throughout the treatment? Because look, for the other paper talking about swelling the cornea. So to me, you've done the same thing using hypoosmolar. It's just a difference. You can cross-link thinner corneas than what the previous paper suggests. The previous paper waiting for it to swell the cornea to 400 micron. then you cross-link. Here you give more options basically for the much thinner corneas.
Exactly.
So did you measure throughout? Because your cornea will, you said the cornea swelling will vary between like 30 micron to 150 micron. So maybe during your treatment, if things are changing all the time as well.
Yes, but the point is, you don't care anymore. You simply don't care. If you have a 260, you look at the final value, and yes, we measure every 5 minutes. The problem with the initial hyposmolaric technique was if you had a cornea of 280, which would not react, and swell to 320, then you would say, oh no, I can't cross-link because I'm not at 400. And now you say, so what? It's at 320, and this is my adapted fluence. That's the difference. Yeah.
I used for this the intraoperative OCT, Samer, that it was my real question when everybody shows a different type of riboflavin. And actually I found that the isoosmolar riboflavin really keep the cornea stable. I also published a paper in 2016, which I demonstrated how the cornea really change if you use hyperosmolar or hyperosmolar. So I go for isoosmolar, and I found that we have a standard deviation of 10 to 15 microns. So you are quite safe that you start with a 400 micron cornea and you end with a cornea that is between 390, and it is the base for all, for cross-linking, for extreme ablation, and for your safety. Because sometimes, you start with a 500 cornea, and when you use a Dresden protocol, just for dehydration for 30 minutes, because the cornea remains without epithelium, the cornea shrink. Then you go 30 minutes of cross-linking and the cornea was cooked. So accelerated cross-linking and rapid procedure, quick procedure really changed our life, Farad.
I agree. But the reason why we didn't, you're right, you can use isoosmolaric, no problem. Another reason we had in the back of our heads is, I'm a little upset about getting from industry L, M, S, P, Q, ISO, hypo, hyper, and so on. I ended up with 8 different solutions. So we chose a slightly hypoosmolaric that would work in epi-off and epi-on procedures and in pack cross-linking. And this is why we said, okay, one that fits as many as we can. So let's use this one to establish the nomogram. Yeah, but you're right. You could do it with other riboflavins too.
But I just use now one riboflavin because I'm really confident.
But you don't do pack cross-linking with it.
No.
Exactly. And we try to simplify to the max. So we want one riboflavin that covers everything. Yeah.
I have a good question from a colleague, a very good ophthalmologist from Morocco. He's very interested in keratoconus, asking Professor Dan Bernstein about which one you think detects keratoconus earlier, epithelium mapping or posterior elevation?
Epithelium first. Because in the earliest stage of keratoconus, the change of the back surface is equivocal, right? When you have a big change, it's obvious. But when you have a very small change, well, I don't know. And the algorithm also says, I don't know.
Yeah.
But if the epithelial thinning is coincident with that little back surface where you say, I don't know, the epithelium, if it's thick, not keratoconus. If it's focally thinner, surrounded by slightly thicker, it's keratoconus until proven otherwise. So, but it could be ABMD and it could be dryness. So remember, there are false positives. But my point is, if you only look, if in 1991, when I first made 93, when I made the first epithelial map and published it in ophthalmology in 1994, if at that point, if Tomei had commercialized this machine that we developed at Cornell in New York, which they were talking to us, if they had commercialized that machine at that time, the OrbScan, the Pentacam, they may have never been developed.
Yeah.
Because combining the atlas or the Posido with the epithelium is the test. You see, so in other words, if you only have one machine, it's not a tomographer. It's just the epithelial measurement. So if you have an RT-View or an Avanti, then you have the most sensitive device for detecting keratoconus.
Thank you.
Even if you don't have topography.
Okay, thank you. I think we need to proceed to the next talk.
I'm just going to mention, I'm going to answer all the questions to me on the chat. And then I'm afraid I need to go because, you know, it's the ASCRS right now, and I have another session that I have to go to. So I will answer all the questions that anybody asks on the chat, and then I will go. So anyway, thank you so much for inviting me.
Thank you, Dan. Okay.
Thank you very much, Dr. Dan. And Dr. Farhad, I think he is going to leave also.
I'm very sorry, yeah, but thank you very much for having me with you.
Thank you very much. The honor is. Thank you, Dan, and thank you, Dr. Farhad. We are very happy to have you here. I will start my talk. I will share my screen.
Thank you, guys.
Hello again. I will be talking about corneal cross-linking, when and how. I will share you our experience. Keratoconus, as we all know, is the most common primary ectasia. It's a bilateral and asymmetrical corneal degeneration with a significant visual morbidity, usually becomes apparent during the second decade of life. Etiology varies, prevalence also varies, and the KMAB study is one of the largest ongoing screening study, and I'm very proud to be part of this study. Its aim is to address the real prevalence of keratoconus. Corneal cross-linking, as we all know, is the photochemical reaction that is made to increase the corneal stiffness in order to stabilize a weak progressive disease. So the first step is to identify those at risk and to identify the progression criteria, which is really a challenge, especially in keratoconus patients, because the measurements repeatability is poorer in keratoconus eye in comparing to normal corneas. Criteria for keratoconus progression, a lot of criteria as increase in any of the key readings by more than 1 diopter, or if we have thinning of 15 or 20 microns, or if we have a change in the manifest cylinder of more than 1 diopter, or in the spherical equivalence, but not in children, because normally in children they get progressive of their disease, even in a simple myopia. So we need to differentiate whether this difference reflects a disease or reflects a normal change in the cornea. So the conventional approach is only to intervene for patients with documented progression. Factors that are predictive of increased risk of disease progression, such as younger age group, those with the steep keratometry, high astigmatism, low visual acuity due to irregular astigmatisms in some areas of the world, like in our areas, the disease is aggressive and tend to progress than in other areas. If we have documented progression in the contralateral eye, and also etching is a very important factor in disease progression. Another factors like pregnancy, thyroid function, thyroid dysfunction, or even floppy eyelid syndrome, or patients with obstructive sleep apnea are at risk. I want to share this case with you. This is an interesting patient, came to my clinic in 2008. He was 25 at that time, seeking refractive correction. He has a pretty good visual acuity, has mild myopia with a cylinder of -4 in the right eye, and a vision of 6/12, and a much better left eye. This is his pentacam, where we can see that there is inferior cone, central corneal thickness of around 450, and it's very obvious in the anterior and posterior elevation map there is a bulge. And the left eye is a pretty good, better eye. There is inferior steepening of 2 diopters, central corneal thickness of around 490, and there is mild elevation in the back surface. So this is in 2008, and patient was asked for follow-up, close follow-up, but this is a Saudi patient, lives across border. He lost follow-up, and he came 8 years later, just coming asking for a checkup. He has no new complaint. He didn't feel any change in his visual acuity. He's now 33 years. His vision almost the same, mild decrease in the right eye, which he is not aware of. We may have increase in his cylinder. And this is his scans at that time in 2016, 8 years after the first scan. And as we can see, there is a severe increase in the cone in the right eye, with progressive thinning. The cornea now is below 400 microns, and also the anterior and posterior elevation, we can see how aggressive the disease. If we look to the left eye, this is something that I want Dr. Dan to comment on this, if he will stay with us, because if we look at the sagittal curvature, we can see that there is improvement in the anterior sagittal curvature. This is only a oblique astigmatism, no inferior steepening, though the cornea is becoming thinner, and there is increase in the posterior elevation. So this is also a progressive keratoconus in the left eye, but to a lesser degree. And this document that patients with a steep keratometry get more chance to progress. This is the difference map. As we can see, there is a 10 diopter progression in his right eye. And even with this huge amount of progression, the patient is even unaware, or he doesn't feel any change in his symptoms. And this is, I consider, a silent disease, as we can consider diabetic retinopathy, where patients get a very advanced PDR with still 6/6 vision. And this is also the same, and this reflects how important is the screening of these patients. So this patient have a increase in the right cornea. If we look to his left cornea, we notice there is improvement in the surface of the axial map of the left eye. I don't know if this is just an tear film instability, or this is a part of the epithelial remodeling. Taking this into consideration, this is also what we see here. This is a child that was brought by his parents because of the eyelid lesion. He has warts. When I look at his hands, I saw the same lesions in his hand, and what is he always doing is keeping itching. And taking into consideration these two factors, we have a very aggressive disease that we need to have a lower threshold of doing cross-linking. I will come to this at the end of my talk. Options available, as you discussed before, there is a corneal cross-linking, the original Dresden protocol of using a 3 milliwatt for 30 minutes, which corresponds to a 5.4 joule per centimeter square. There is a lot of development in the devices. This is the device first used in the late 90s by Professor Zeiler, and now we have a very sophisticated and advanced devices like the one that was developed by Dr. Farhad to be used on the slit lamp. So the different corneal approaches, as we all know, there is the epithelium off and the epithelium on. We have in the epithelium off the accelerated and the epithelial on. And what we noticed here that all these approaches, they only address one element of the corneal cross-linking, which is the riboflavin. And these approaches works on the riboflavin to facilitate a diffusion, while, as we all know, that the principal components of cross-linking is riboflavin, oxygen, and light, and they do not address the oxygen at all, even the light. So these maneuvers, the epi-on and the epi-off, they all address the riboflavin metals and neglecting the oxygen. And this is a study done, published in 2013. And what they did at that time, that they cross-linked corneas in normal oxygen level, and they cross-linked another corneas in a chamber filled with helium where there was no low oxygen. And when they measured the biomechanics, and they have a third arm like a control without cross-linking, and when they measure the biomechanical stability, they found that corneas cross-linked at low oxygen are very similar to corneas that are not cross-linked, which they came to a hypothesis at that time that biomechanical effect of cross-linking seems to be oxygen dependent. That means if we don't have oxygen, we don't have cross-linking. And we all know that the epithelium is a big consumer of oxygen. It consumes more than 40% of the oxygen available of the cornea. And if we calculate this based on the unit volume, we find that the epithelium is utilizing 10 times that of the stroma. So the epithelium is not only acts as a barrier to oxygen, but also it consumes most of the oxygen available, and also it consumes most of the energy that is delivered. If we come to the epithelium off techniques, the original Dresden protocol, it's very well established, and most of the studies document that the the protocol is effective in arresting disease progression with more than 95% get stabilization. Even half of these get a regression of the disease and without any relevant side effects. And then came the idea of using accelerated cross-linking depending on the Bunsen-Roscoe law of reciprocity, which states that for a photochemical reaction, if we maintain a same total energy, then we will get the same reaction. But this is not the actual in the real life, because as we get shorter duration, increased irradiance, we will get less effective, as documented in this study in 2014. As we get cross-linking using higher irradiances, then the biomechanical effect will be less and less. But in real life, the difference between the 3 milliwatt and the 9 milliwatt protocol is not very significant, and that was the rationale among a lot of surgeons worldwide is to use the 10 minutes protocol. And again, the oxygen was the limiting factor leading to reduced treatment efficacy in the accelerated cross-linking. Then they started to try to replace dextran with the HPMC, and the rationale behind that was the dextran is associated with a shrinkage of the cornea of up to 20%, while the HPMC is associated with increase in the swelling in the cornea while maintaining the same concentration gradient, and this is published in the JRS in 2016. Another similar study that studied the difference between dextran versus HPMC and published in the cornea in 2018, where they found that the dextran group get a shrinkage of the cornea by more than 50 microns, while the HPMC get an increase of more than 100 micron. And this actually is very close to what we found at our hospital. This is a series of some patients that we cross-linked at our hospital here in the Middle East, Eye Hospital in Amman. And what we found that there is almost more than 80 or 85 microns of corneal swelling after 30 minutes of soaking with riboflavin with HPMC. But this should not be at the cost of efficacy. This is a study published in 2018, which studied the efficacy of cross-linking using dextran versus HPMC. Although it's a small study, but they found clearly that the dextran-treated group had a greater improvement in best spherical corrected visual acuity, but both groups document that they have the same or similar decrease in the Kmax readings. So both groups, maybe the dextran group is more effective, slightly more effective, but both are effective, and this is what we are noticing in our practice. So to summarize, this is the scheme I usually follow in our patients. If I have a patient coming in for assessment, if the patient is below 26 years of age, I usually cross-link all these patients below the age of 26 years, unless I have a very proven evidence that his cornea is stable. Otherwise, I cross-link all patients below the age of 26. If the patient is above 26 years of age, I look at the etiology. If it is a post-LASIK ectasia, I usually cross-link early. And some colleagues, even if the patient is 50 years, and some colleagues sometimes say that this is a 50 years old, why to cross-link him? But why from the first to begin with, why he developed ectasia? So any patient developed ectasia, we need to be aggressive with management him and not to wait. And if there is a progression in the contralateral eye, this is also a strong indication to cross-link both eyes. And if the cause is a primary keratoconus and is stable, we usually follow these patients every 3 to 6 months, and then we can go to the other pathway of visual correction. And if the disease is progressive, then we go to the cross-linking. And our protocols here, if we have the corneas more than 400 micrometer after removal of the epithelium, I usually prefer the epithelium of either using dextran or HPMC. And if the epithelium is, if the stroma is less than 400, I can go down up to 380 or less, even to 360. And I'm very comfortable with the HPMC causing swelling of at least 40 or 50 microns, but we need to be very cautious in these cases. Some advocates using iontophoresis in corneas up to 380 micrometers. If the cornea is below 400, we have nicely presented by Dr. Farhad Hafidi, the sub-400 protocol or the M protocols. To summarize the take-home message, always screen, always ask patients not to rub their eyes, and cross-linking is a treatment of progressive disease rather than, it's not a prophylactic treatment to prevent the occurrence of the disease, it's the treatment of progression. The future is the epi-on for sure, and always respect the 400 micrometer minimal corneal thickness before applying light, and respect the 10-minute irradiance if you are doing the epi-off protocol, the standard protocols available. And again, screen and screen. Thank you very much. Now I will stop sharing my slide, and thank you. Dr. Dan is still with us.
Yep.
Do you want to comment if you want to leave, or?
Oh, no, I mean, what would you like me to comment on? I mean, I have nothing to say. You're showing a lot of, you know, really severe disease. And I think that if you're able to see changes on difference maps on a tomographer, then you are within the, you're already past the threshold that you would need epithelium for, if you see what I mean. It's when what I was showing was when the topography was completely stable and the refraction was stable and the keratometry was stable and the wavefront was stable, but the epithelium was showing that there was still continued flattening. So what you're showing is absolutely, yeah, standard of care. You've got gross changes that are detectable by tomography. Epithelium comes in when you're looking at detecting the earliest changes or subsurface changes. Yeah, great. I mean, you have, where you work and where you live with your population, you have a big job there to do.
Yeah. Do you want to comment on this epithelial map or on this axial curvature? We have an improvement in the axial curvature, or this is just,
I mean, it's a lot flatter, right? I mean, it's a almost 2 diopters flatter in the center. But again, remember the pentacam isn't great for central data. Because the pentacam is only Scheinflug, and so it's a sweep across, and it you know, eye movements, and the pentacam does a lot of smoothing. That's why the back surfaces, if you do difference maps of the back surface on the pentacam, it often looks like a random, you know, like a sort of modern art painting, right? Because I mean, back surface difference maps.
Yes.
Yeah, because it's not repeatable. With the MS-39, I keep on mentioning this. People are, I should buy shares in the MS-39. I mentioned it so much. No, with the MS-39, I will do cases where I would, you know, like I will do a 1-year post-op MS-39 on a very high myope that I've done, you know, SMILE on. And the back surface difference map is green, like zeros everywhere. In other words, it's actually showing no difference. And the same eye, if I do a difference pentacam map, there's a yellow bit here, there's a red bit there, it's random. So the pentacam was great in 2006 when we had nothing else. And it was certainly much more robust than the orb scan, although the orb scan, I think, was more accurate on the back surface, but it was harder to get a good exam. And so the nurses prefer the pentacam. But I think it's because the pentacam does so much more smoothing. And the development of the orb scan basically stopped by about 2002, 2003. There was nothing new except obsolescence engineering.
Dan, let me add a comment here on the difference between the OCT and pentacam Scheinflug after cross-linking. I'm using the OCT, the MS-39 for 3 years, and on every single patient who had cross-linking, I have his pre and post-operative with both the Scheinflug and the OCT. Big difference in the corneal thickness measured with the OCT versus Scheinflug, especially after cross-linking. Yes. Preoperatively, not a big difference. After cross-linking, the difference might reach 30 microns, simply because the Scheinflug is an option. device, and it's affected by scatter, which increases
Yes.
after any kind of surgery, especially cross-linking. Even after
Yes.
LASIK, SMILE, or whatever you do on the cornea, you have more scatter, so the thickness measured with the Scheimpflug is not accurate. And it's very sad to say that most of the publications who are reporting the change of corneal thickness after cross-linking are using the Scheimpflug, which means they are
Yes.
not close to being accurate. So that was my comment. Thank you.
Yeah. Well, you know what would be
Yeah.
amazing, Ala, if you could take, I don't know, 20 eyes, kind of match them pre-op before the cross-linking, like 5 grade 2s, 5 grade 1s, 5 grade 2s, 5 grade 3s, 5 grade 4s, and you have your Pentacam model monitored patients, and then you have your MS39 monitored patients. And if you publish the difference maps for the same eye between the two devices, I think it would be it would be a funeral for the Pentacam in terms of the difference maps, because particularly the back surface.
Yeah.
Maybe the only reason I want to do this is I don't want the Oculus people to hate.
Yeah, but see, that's the difference between you and me. Yeah. I don't mind telling the truth if it upsets someone.
Well, no, I mentioned this several times on different meetings, and I showed some cases measured with both machines. And, I had this very long discussion with Theo and John Marshall, with the Avidro guys. And I was really clear about it that we should not go with any post-operative measurement with the Scheimpflug.
Can I just I'm going to just say I very much appreciate what you said there, and I'm looking here for, yes, here it is. So Robert Maloney at George Waring's memorial service in Atlanta, which I know you would have loved to be there, and there were very few people there because it was just arranged very quickly. But Robert gave the eulogy. I played the saxophone, actually. In fact, I wrote a piece for George called For George, and I played it at the memorial.
Oh.
And Robert said, he said some words in his eulogy, which I've written them down and I use them as a reference. Okay. George Waring, he offended people by speaking the truth about bad ideas. His eyes would twinkle when he'd said something provocative, inviting us to react. He reached out with encouraging words for young investigators wherever he went around the world.
That's nice.
Do you
Very
remember?
nice.
Thank you.
That was him.
Yeah. Okay.
Nice, yes.
Yeah.
Thank you very much. I think
Yeah.
we need to proceed. We are a little bit late.
Yeah.
Dr. Miguel, please.
Before you go, just I'm the speaker.
No, Dr. Miguel. We'll have Dr. Miguel, then Dr. Muhammad.
Yes. I think
this one. This
I
screen
think I think I am the line.
In the line, we have Dr. Miguel, Dr. Ala, please. And then Dr.
Yeah.
Muhammad, and then we will have you, if you excuse us.
Okay, so I just want this is I'm not going to present. I'm just showing this case
Yes.
with the corneal with the post cross-linking measured with the Scheimpflug, with the Pentacam. This is the pre-operative. This is the post-operative, and the differential map shows 35 micron of thinning. The same eye on the same day of the same patient, of course, had OCT before and after, and the difference is only 8 microns. So this is just to show the point that there is a big difference between the measurement with the OCT and the Scheimpflug. So that's what I just wanted to share with you.
Thank you very much. Thank you. Please, Dr. Miguel, please start sharing.
Okay. Yeah. So thank you for inviting me. As a little story, we also told you that with the orb scan, when we start to do the cross-linking, the orb scan sometimes took the demarcation line as the posterior limit. So sometimes he measured something like 200 micron cornea. That's it. That just for showing you how the Orbuscan and the shame flag technology is dead, especially when you perform cross-linking. So really, go versus OCT is the only way. So more than this, let's start with my presentation that will cover the refractive surgery treatment option for keratoconus. I am not mad, so you can do some kind of ablation on the keratoconus, and I will show how to do also with a safety profile. This is not really my idea. If you look at the literature, you can also find this paper in which more than 15 years ago, someone speak about performing PRK or PTK in keratoconus cornea, but without cross-linking. So they didn't show follow-up data, so I really fear about this, but this is not really my idea. And by the time, you can find the literature a lot of protocols about combining cross-linking with the excimer laser ablation. So when you approach this kind of surgery, you have to think different, because if you want to do some kind of refractive surgery, the main targets here are not to keep the people away from glasses, but to regularize and stiffen the ectatic cornea, reducing the corneal aberration, improving the best spectral corrective visual acuity or postoperative contact lens fitting. And refraction is always a secondary target if you can. So never give a false illusion to you and to your patients. So there are some challenging concepts if you want to convince the old-fashioned colleagues about this kind of surgery, or better informed patients. So the problem is not the thickness of the cornea. The problem is the stiff. You cannot compare a 6-element Lamborghini that in which the elements are less than half thickness with respect to a Lamborghini Miura, just because the 6 element is carbon. So carbon is more stiff. So the cornea, you can have also a 300 micron cornea, but if the cornea is stiff, it will react better than a 500 micron cornea with the keratoconus. So the problem is that you have to look at a minimal ablation, usually less than 30 micron, but you will compensate the ablation if you cross-linking the cornea, because the cornea will be more stiffened. So when you have to consider to add a refractive laser procedure to your normal cross-linking, essentially, if you look at this nomogram, you can see that you can really think about this when the patient have unacceptable visual acuity. If the cornea is stable, but also if the cornea is in progression. So the limit is the visual acuity, the corrected visual acuity. So you have to think now when the patient comes to you and say that, okay, I have a keratoconus, but I cannot correct well also with the contact lenses. So try to think at the visual acuity and also and the visual quality of the patients. And if you want to approach this surgery, the using of a cutting edge technology is not really an option. And I will show how. So this is what we was discussing. In the 2012, I started to do intraoperative OCT to all my patients. And I noticed that when you use dextran in your riboflavin solution, so when you use an hyperosmolar solution, you start with a 500 micron cornea, but just after imbibition, 30 minutes, your cornea shrink more than half. So you start with a 500 micron cornea, and you perform cross-linking after 30 minutes with a 300 micron cornea. So this is very risky. And this was the first cause of corneal burning, scars, endothelitis, etc. So that's why I moved versus a dextran-free riboflavin formulation that actually is what I use, because I demonstrated with the same technique that you start with a 500 micron cornea and you start to cross-linking, the cornea is quite the same. So if you want to approach also to laser surgery, you have to be sure that the cornea is the same during the treatment. And the other things for which you have to go to the cutting edge technology is that the oldest cross-linking machine has they had an uneven beam profile, so they release more energy into the center, but not in the periphery. So that's the reason why you notice that with the old machine, a more flattening effect in the center respect to the periphery. And you can easily recognize this if you look at the demarcation line. In the newest machine, you have a top hat optimized flat beam. So the energy delivery is the same from the center to the periphery. And you have a demarcation line that is quite at the same depth from the center. And if you look also at the periphery. And remember, the keratoconus is usually an ectasia of the peripheric cornea, not from the center. The other question is to customize the cross-linking volume. So you cannot cross-linking a 500 micron cornea with the same energy of a 400 micron cornea. So you have to be sure how much depth you will go. That's the reason why we start to analyze all the energy and all the power of the cross-linking machine. And we tried with the Cosimo Mazzotta to set a nomogram. So now I can easily say that if you use the same riboflavin, we can predict with an error of 10 to 15 micron the depth of the demarcation line. So we are quite safe also in the thinner corneas. And that's what Cosimo called the M nomogram. So we usually use the rule of the 2/3. So if you want to be safe, you have to cross-linking 2/3 of the cornea, not more. So you have to float at the same and a safety level. The M nomogram that you can show that you can see now just easily show to you how much energy used to reach a good demarcation line depth in each kind of cornea. So this is important for the safety. And if you want to add also excimer laser surgery, this is mandatory. This is my third protocol that I presented in 2016, in which in this paper we presented a lot of technique to improve also corneal shape, not only to halt the keratoconus progression. The TransPRK, to my opinion, is the only way to perform this surgery, because if we know how the epithelium, how the epithelium acts in keratoconus, we know that epithelium usually is thinner in the apex of the cornea, and we can use this to set the excimer laser to regularize just the apex zone, not further. This is actually my platform, but this platform could be replicated also with other laser and cross-linking technology. So you need a laser which is capable to perform TransPRK or TransPTK, and you need a device in which you can set power and also energy deliver. So I actually use the CI device, but also Vedro KXL. But this is not important. The important is the customization. This is the concept, and this is the real life. when you perform trans-PRK and you remove epithelium with a standard 55 to 65 micron fashion, you will notice that you will remove also some stroma in the apex zone, because the epithelium is here is thinner. But sometimes in the normal cornea, in the non-ectatic cornea, you will also leave some degree of epithelium. And this is important because with this kind of laser ablation, you will focus more the treatment of the further treatment of cross-linking just in the ectatic zone. So you will focus the cross-linking just on the ectatic cornea. So you first remodel the cornea with a laser, with excimer laser, and then you will fix the new reshape of the cornea with the cross-linking. This is the real life. The beauty of this kind of surgery is that you really do not touch the patient. So the patient really stare at the laser and the laser beam, and all the procedure is really touchless. So this is the first phases in which I remove the epithelium, and if I can also do some customization for stromal ablation, and then I perform accelerated cross-linking. So the procedure takes about 18 minutes at all. So it's very also easy for the patient. The good things about epithelial map after this procedure is that someone demonstrated also that you also not only regularize the stroma, but you also regularize the epithelial map. So before the treatment, epithelium is thinner, and after the treatment, in most of the cases, the epithelium is quite even. So this is better also for coma. I do not have too much time to discuss about this, but in summary, you have to look also at where is the keratoconus. When the keratoconus is a peripheral, you can't be more aggressive, because you can go after the treatment in a myopic shift. So the better way to start this kind of surgery is the central keratoconus, in which you really act very well on the coma component, and you can easily miss the myopic shift. The other improvement that I did in my surgery is to shift ablation not on the vertex of the cornea, but on the apex of the cone. This is important because I reduced the volume of epithelium and stromal ablation, and also I focused the treatment just on the cone area. So I will have also less stromal ablation on the apex. This is some practical cases. It was a male that was rejected from fire department because of the poor visual acuity. He has a little cylinder that I treat in halfway, and I also shifted the ablation just over the cone area. And after the treatment that took less than 60 micron of a tissue ablated, I will result in a 10/10 uncorrected vision after 3 months. And if you look at the map, is really beautiful. This is another cases in which the patient was also myopic and have a cylinder of 6. And after the treatment that was really customized on the central zone, I have a regularization of the astigmatism, and now he can see very well with a cylinder. So in these cases, the treatment took less than 20 micron, but what was good, that the patient can see now very well also with the spectacle, because it has a real more regular astigmatism. This is another cases, and sometimes you can just remove the epithelium, and just removing the epithelium sometimes is very good for also for improving the coma aberration, because for example, in these cases, if I go here for a real trans-PRK ablation, I will waste a lot of tissue. But in these cases, I just do some epithelium removal with the laser, and I have a beautiful result. So the real target is not to look at the refraction, but to look at the coma reduction, because the main target here is the aberration improvement, not the refraction. So the patients are very happy because they are less blur in the night, less blur also in the day, and they can easily now have easily put a contact lenses, and they will have very less coma. So this is another example in which I use a different approach for the same patient. In the left eye, I did the topo guided trans-PRK because the cornea has a less pronunciated cone, and in the fellow eye, the right eye, I use just removal of epithelium. And if you look at the plane ablation, in the left eye, in this case, I always use a minimized depth protocol, because in this case, it allows me to save 22 micron % of tissue. And this is the result. In these cases, my ablation go further than my plan, because I ablated more than 61 micron, but I have a beautiful result in terms of coma. This is the right eye. In these cases, I just remove the epithelium with the laser. I shift the ablation versus the apex of the cone. And finally, I have a thickness difference of 26 micron, but also a good reduction of coma. But STERIX is for many, but not for all, because if you look at this kind of nipple cones, very, very steep and very, very small, if you look at the cone area, it's impossible to do a topo-guided ablation here. So in these cases, if you just remove the epithelium, and if you follow the rule of primum non nocere, look, if I just remove the epithelium, like in these cases, and if you look at the number, I just remove the 3 micron of a stroma, you will have also a beautiful reaction of the cornea, because remember, the cornea will continue to flatten for years because of cross-linking. So when you perform a laser excimer ablation, you have to think that the cross-linking will act for years and will continue to flatten the cornea. So the great aspect of the surgical approach is not only the quantitative improvement, but also the subjective improvement in quality of vision. And you can also combine this with the intracorneal rings or additive procedures like CARES. And the STERIX and cross-linking alone reduce, but will not eliminate the need for corneal transplant. That always remain the last surgical option when this kind of parasurgical strategy fail. So the most important things is to take care about patient selection, because sometimes, as you can see, a good intention will not ever lead to a good results, like in these cases. Okay. And I would like to thank you for your attention, and keep in touch. Bye.
Thank you very much. Very impressive Now we will move to, we are a little bit late. We will move to Dr. Muhammad Shafiq. Please start sharing your screen, Dr. Muhammad.
Just a second. Well, can you see the screen well?
Yes.
Okay.
Yes, please.
Okay. So thank you very much, Dr. Khalid, for your kind invitation and for allowing me the opportunity to share my experience with these distinguished guest speakers. My talk today is about refractive surgery after corneal cross-linking, which is actually a recipe for visual rehabilitation of patients of keratoconus after halting the disease itself. I have no financial disclosure to show in for this topic, and okay, so why it's not advancing? Okay. So I start with quoting the FDA panel when they approved the technique of corneal cross-linking. They had very nice words that we have now a historic chance to treat a disease that had no treatment before. And by this, they mean, of course, the keratoconus. And I add that we have to get the maximum benefit out of it. And as we know, our ultimate goal or the best result that we can achieve by a good corneal cross-linking, whether it is accelerated, non-accelerated protocol, AP on, AP off, the ultimate goal is to have a centralization of the cone, a cone shift, a more regular central cornea, and what I call a refractable eye, an eye in which you can measure the sphere and cylinder precisely to address the vision later on. And as we know, modifying the irregularity in the pupil entrance is the main goal and reason for visual rehabilitation. This is our aim for refractive surgery after any kind of corneal cross-linking. And I think the refraction or the refractive surgery could start at the procedure of the corneal cross-linking itself by simply removing the epithelium by a PTK circle. And now in the era of the epithelium mapping, this presentation is before the era of the epithelium mapping. But now with the epithelium mapping that we have learned precisely from Dan Reinstein now, we can help, it can help a lot to achieve what we are aiming for. As you see, if you can just plan your epithelium PTK circle removal to a 50 microns, and the epithelium is like 20 to 30 microns above the cone, so we can simply shave the cone. And by simply shaving the cone, we allow a better penetration for the riboflavin as we disrupt the Bowman's layer, and also we achieve a kind of regularity. And I demonstrated clearly in many of the cases how we can see, as in this right eye, the regularity in the central cornea by just a PTK circle and corneal cross-linking. You see how regular is the cornea in the center, and in the left eye of the same patient, which had a higher irregularity from the corneal cross-linking, we can see now a better, more or less irregular astigmatism that paves the way to improve the refraction or the refractive procedure you're going to have afterwards. And if you track your patients for many years, as I did, and I published my data in the Journal of Refractive Surgery of a 7-year outcome of the epithelium of corneal cross-linking using my technique, you can see clearly that the majority of the results and the impact on the Kmax and the anterior and posterior elevation takes place at its utmost in the first 6 months after the corneal cross-linking. All the significant changes, and it has also its impact on the best corrected and uncorrected visual acuity. Everything takes place in the first 6 months. So if you wait maximally for 1 year, there will be you will have a stable cornea. But you know what we know, all of us, that corneal cross-linking by itself is not enough to allow the patient good vision. It is just a step to regularize the cornea, halt the disease. Nevertheless, the patient is still complaining of a poor quality of vision because of the degradation of vision of the higher order ablation. So in the past, we tried many profiles to improve this irregularity on the cornea, and we tried various types of topo-guided ablation profile to improve the regularity of the cornea and to take out the noxious higher order aberration in spite of the relative insufficiency. Because by that time, if you try to read the irregularity of the cornea by a kind of a barometer, which was a low definition barometer and a low resolution one, we didn't have a repeatable and reliable maps to depend on to do a perfect ablation profile and a reliable ablation profile to regularize the cornea and remove the higher order aberration. But since the year 2012, I acquired a high definition Hartmann-Shack sensor like 8 years ago that was able to read the majority of the irregular cornea. And this is to show how many points we can read from a 7mm pupil. It is just 5 times the points that you can read through through a 7mm cornea, 5 times more than the low definition aberrometers or the low resolution aberrometer that we were using in the past, and they were short of reading the irregular cornea clearly. So the question when I acquired this 8 years ago is to try to answer, is this kind of high definition aberrometers, this time it was the iDesign, I have no financial interest in it, and that now in the market there are many high resolution aberrometers. If these, are these aberrometers able to solve the problem and the dilemma of the irregular cornea? So I led a pilot study that I was published in the year 2015 with my colleagues to address different kinds of irregular corneas, and by that time I addressed the 3 types of irregular corneas: the cornea post-RK, the cornea after irregular LASIK like descendant ablation, and of course the commonest type or the commonest pathology of irregular cornea in our world, which is the keratoconus after corneal cross-linking. The success that we had by that time led us, or led the group, to extend the study to a more ample sample of 34 eyes that we followed up for a year. And these eyes had 1 year after corneal cross-linking and stabilization of the cornea, had a spherical equivalent less than 6 diopters. The patient age was 21 years or more, and the corneal thickness that we treated more than 400 microns. And I published this protocol that was a paradigm shift in the treatment of cornea after corneal cross-linking in the Journal of Cornea in 2016. This was a change of the protocol to do wavefront guided PRK after 1 year of corneal cross-linking. And I got a very nice results. Actually, we were able to decrease the amount of noxious coma, trefoil and spherical aberration, and the total RMS value was reduced, something to improve the or explains the improvement of the visual quality. Also, 5 out of the 8 indices of irregularity got a significant improvement after these results. And in this sample of 34 eyes, we were able to attain 20/40 uncorrected visual acuity after this protocol in 97% of the patient, something that you can tell your patient or promise your patient, if you select him well, that he can get rid of his glasses and lead a glasses-free life after this kind of surgery. The cases are many, but just for the time, I'm going to show just one case for a 24-year-old lady that had 1 year before the corneal cross-linking, and her vision was stable with this manifest refraction of high cylinder, which is actually a translation of the coma, not a true cylinder, with a best corrected visual acuity of only 0.3. You can't improve more than that with glasses because of the higher order aberration and the coma. We can see how irregular the cornea at the pupil entrance, and by reading this cornea with the high definition aberrometer, you can see the exuberant coma that degrades the vision of the patient. And of course, out of this, you can generate an irregular ablation profile powered by the high definition aberrometer. And of course, it will be guided by the iris pattern registration to ablate the cornea. You just go and remove this time the epithelium, because the epithelium after regularization of the cornea is more or less regular, not masking too much. And after which you do a PRK and terminate by applying a mitomycin C for 20 seconds, as we taught from previous experience, to reduce the incidence of haze. After which you can regularize the cornea, as we see in the post-op. The cornea is much regular in the center, and actually you don't seek perfection, but this regularization improves a lot the vision. Just by removing 47 microns from the center of the cornea, you can achieve such nice uncorrected visual acuity of 0.7 and a best corrected visual acuity of 1, something you can never do with any kind of keratoplasty. And if you compare the indices pre-operatively to the post-operatively, we can see that all the numbers has reduced. Some of them has converted to yellow and white instead of the red. This is an indication that you regularized a little bit the cornea to improve the point spread function, as we see, to such nice point spread function, because you got rid of the noxious coma. The examples are many, but having the results of this protocol, I don't do anymore the Athens protocol or any kind of simultaneous topo-guided ablation profile with corneal cross-linking. I mean, a PRK with corneal cross-linking simultaneously, I abandoned it totally, and my protocol now is to a sequential wavefront-guided PRK after 1 year of the corneal cross-linking. I do the corneal cross-linking, I wait for 1 year to stabilize the cornea, and then do a wavefront-guided PRK with mitomycin C, aiming to reduce the higher order aberrations. And I have many reasons to say why sequential and not simultaneous PRK with corneal cross-linking, and why wavefront guided ablation and not topo-guided ablation. Because first of all, if you do the corneal cross-linking and the PRK at the same time, this is too invasive to the cornea, and this is too much insult to the keratocytes, and you might end up with such a disastrous delayed epithelial healing that we suffered a lot of doing the simultaneous corneal cross-linking with topo-guided with a PRK at the same time, but because you have a double insult to your cornea. But if you do it separately, you will have better results, of course. A second, you don't take into account the effect of the corneal cross-linking. Sometimes the corneal cross-linking has an exaggerated effect, and instead of just regularizing the cornea, we flatten the cornea, we over flatten the cornea, like in this example, from a pumpy cornea to a too flat cornea. In this example, in the keratoconus, you will end up with a high hyperopic shift. So you might end up with +5, +6, or even +13 in some cases of hyperopia, something you can never treat any more except by doing a keratoplasty. So you have to wait for the effect of the corneal cross-linking and the maximum flattening, and then you go and plan for your PRK. And then also, you don't address emmetropia. We have a nice chance, if you have a relatively thick cornea, to take off the noxious coma and the higher order aberration, as Miguel Riquequi just show us how to take off the coma, but also the sphere and cylinder. And so you can correct the refraction of the patient, not even, I mean, to a perfect extent like the refractive surgery, but to take out the thick glasses or to take out the sphere and cylinder. But if you do them simultaneously, you don't have a clue for the final refraction, and you might go back to correct the refraction by other refractive modalities. And lastly, the drawbacks of the topo-guided ablation profile themselves that we were using in Athens protocol, because the majority of the Placido disk topographers on which we depended to create a topo-guided ablation profile don't read the dead center. They extrapolate the central data. And we know that the center is the problem, because in the dead center, this is the extreme irregularity and extreme coma that degrades the patient's vision. And for me, using a topo-guided ablation profile is just killing an ant with a sledgehammer. You bombard the cornea with a big shape ablation profile instead of using a fine brush of a wavefront guided ablation profile to remove the coma. And this was commented by my dear friend Gustavo Tamayo even before the era of the aberrometers, that using a topo-guided ablation profile to treat the irregular cornea is lacking what is called the cause-effect relationship, while using a kind of a wavefront ablation profile is addressing properly the cause to have a nice effect, which is improving the irregularity of the cornea. So we can have a better cause-effect relationship by addressing the central irregularity in the pupil entrance that address the visual degradation. Yes, we can. If we can read these degradations, we can treat them. And of course, the wavefront guided profiles nowadays can solve the problem that just mentioned by my colleague Mega Rikiki a few minutes ago about the centration, while to center on the apex or to center off the apex of the cornea. By reading the cornea with a wavefront data acquisition or an aberrometer, you're just doing a pixeling of whole pupil entrance, and you create out of it a dependable aberration profile that is just adjusted that the beam will take place in the correct place on the cornea to regularize it, using the cyclotorsion compensation and the pupil centroid shift and pixeling all the pupil entrance with the wavefront data acquisition, because we need to flatten the peak and to make the laser beam hit the peak exactly to regularize the cornea. But if it doesn't hit the peak exactly and fall off the peak, it will end with more irregularity of the cornea. That's why I prefer a kind of wavefront guided ablation profile. I know, and I'm conscious that we are ablating by this way and already cross-linked stroma, and this might be a criticism to the sequential, but I have my guidelines that was published and I am sticking to it. You shouldn't exceed 15% of ablation of the corneal, the central corneal thickness. You should leave the cornea more than 400 microns at the end of your procedure. You might do a selective higher order ablation that can be done by some machines to save the tissue. And in my machine, which is Vesic Stars, you can do what is called the physician adjustment to take off the sphere and leave only the cylinder, which is an expression for the higher order aberration. You can adopt your nomogram to compensate for the cross-linked tissue, and you should keep an eye on a close follow-up for the ectasia progression signs after you do this technique. You might have a progression in some cases, so you can do a recross-linking immediately. Nevertheless, I never had that with my patient if you stick to the above rules. My point of view now is being, propagated, a lot of publication. This one was a couple of years ago by one of my colleagues, and he was my fellow in Dr. Bardan in United Kingdom now, that proves my point of view that sequential is better than simultaneous. A lot of publications are now using other refined techniques, like other than the total ocular wavefront, like the corneal wavefront. All of them lead to the same point of view, but this is also sequentially. And then I come to the last part of my talk, which is, what if the patients terminate with a high sphere and cylinder after corneal cross-linking, like this patient with a beautiful flattening, but she terminated with -9, -4 cylinder with a best corrected vision of 0.4 and -4 and -3 cylinder with a best corrected vision of 0.8. Actually, what I do is a toric ICL, and I will leave this, of course, for Dr. Danasori. He will address properly the phakic IOL, but rapidly, I use a toric ICL peacefully and nicely to correct the sphere and cylinder for these patients, measuring the K readings, anterior chamber depth, and wide to wide to prescribe or to send the company for it. And if you implant it correctly according to the guideline, the kind of patient, the same patients that I show after 1 month, you can see nicely the ICL and the shadow of the ICL with an improvement of the uncorrected vision more than the best corrected vision, because we improve the vision very near to the nodal point. So she gains line always, the patient gains line with this. I have a case series of toric ICL after corneal cross-linking now of 83 eyes followed up. 67 of them are followed up for more than 9 years. They are stable. They show marvelous results. And the most important piece of fact that you should take care that there is a big difference between what is called the objective and cycloplegic refraction of those patients and the subjective refraction of those patients due to corneal multifocality. And we have taught from other colleagues and from other study that there is a shifting of the line of sight in keratoconus. So what are you measuring actually by autorefractometer or even by a barometer is totally different from the true refraction. The patient is seeing from other point that you might miss. So you should depend totally on the subjective sphere and cylinder and axis. And these are my guidelines when you prescribe a toric ICL to be implanted in a cross-linked keratoconic eyes. You have to take into consideration that you are implanting a phakic IOL under an irregular cornea. So you have to wait at least a year after corneal cross-linking to get sure of the stabilization. And then you should verify the subjective, and again, subjective and not objective, sphere, cylinder, and axis by yourself on 3 consecutive monthly visits. So your patient should come to you on 3 months, and you should get sure that these subjective sphere, cylinder, and axis that gives the best corrected vision for the patient are constant and not changing. And not much advisable for the patient with the toric ICL is not much advisable for the patient having a best corrected vision actually less than 0.3, because if they have a best corrected spectacle correction less than 0.3 or 618, this means that the patient has high order aberration and the nipple of the cone is so downward or off center shifted that he will not be very much satisfied with the toric ICL. And then you should give your patient a trial of a spectacle correction for at least a couple of weeks before implanting the toric ICL or ordering even the toric ICL. If he comes to you happy with the glasses, then you can assure him that he will see much more better than the glasses, because he will gain lines than more than the spectacle with the spectacle correction. The data and the guidelines are published in my publication in Cornea 2014, and this, for my knowledge, is the longest published follow-up period for toric ICL in cross-linked keratoconic eyes. It was a 3 years follow-up, and I'm looking forward to publish 10 years follow-up for my stable patients. And here are my results collectively after 3 years. The patient improved from a pre-cross-linking best corrected vision of almost 0.6 to a non-corrected vision of almost 0.9, because we corrected the vision. This is uncorrected visual acuity, and this is the best corrected visual acuity. Their best corrected visual acuity, we had a better non-corrected visual acuity than the best corrected visual acuity pre-operatively, because you corrected the vision by 2 ways. First of all, regularizing the cornea, regularizing the pupil entrance, and then correcting the sphere and cylinder on a plane very near to the nodal point, which makes a magnification of image and improving of the organic of lines. This is the vaulting of the ICL over the time, and we can see a stable vault. And in those cases of keratoconus, you have the leisure of having a deep anterior chamber. So don't be afraid to oversize a little bit. If you are comparing between, for example, 20.6 and 13.2, go for 13.2 lens, because you have a thicker cornea, you have a deeper anterior chamber. So you don't afraid too much of overvaulting like the other cases. Of course, the surgical technique, you all know, this is a marking of the 19 and 180 axis with this Noit's air bubble marker. And the surgical technique, I leave the surgical technique for Dr. Donatori. I'm sure that he's going to address in more details the toric ICL. My conclusion is a refractive surgery after corneal cross-linking are in fact, all refractive surgery, a recipe for visual rehabilitation. And I think every one of us has his own recipe and guidelines, and all of them work. Customized excimer laser ablation in the era of high definition aberrometers can address properly and selectively even the higher order aberration, and can improve even the low sphere and cylinder if the patient had a thick cornea or ample cornea enough to correct their refractive error. And of course, this will lead to improvement of the vision using the patient his or her own cornea without doing any kind of intracorneal ring segments or any kind of intracorneal implants or any kind of keratoplasties. Again, phakic IOLs, and especially here the toric ICL, can address the high sphere and cylinder post-corneal cross-linking, and we are still in need to provide more refined and consistent protocol and a uniform one for post-corneal cross-linking visual rehabilitations. If you're going this year, and I hope that the ESCRs of Amsterdam will be held, I invite you to attend my course on modern management of a regular cornea. Lucky enough, I am maintaining this course for 12 consecutive years on the podium of ESCRS, and in the past it was on the ASCRS and the American Academy of Ophthalmology with distinguished speakers in the course, as you see. And I thank you very much for listening. This is the view from my window this morning in Alexandria, hoping to see you all in my beautiful city soon. Thank you very much.
Thank you very much, Dr. Muhammad. We will move now to Dr. Ala Dinosauri. He will talk about phakic lenses in keratoconus patients. Please, Dr. Ala. Dr. Muhammad, please stop sharing your screen so Dr. Ala will be.
I will.
Okay, perfect.
Yeah, now.
Dr. Ala.
Okay, I need to share my screen. Well, I think can you see my
Yes, I
screen
think
now?
we'll start shortly. Yes. Can I ask the doctors, please, if you can answer some of the questions on the Q&A box, please?
Dr. Muhammad is here or gone?
Yes, I'm here.
Yeah. While we're waiting for Ala, can I ask you a quick question? Right?
Yes, of course. Yes, of course.
Obviously, wavefront technology is amazing, but I don't think it's widely available. So we talk about technology that's working very well, but unfortunately, not many surgeons can do it. And my second question about using mitomycin C in cross-linked corneas, because you showed that in the video. Some people agree or disagree with that. What do you think?
First of all, let us start with the use of the mitomycin. As we know, the previously touched cornea, any kind of previously touched cornea, even a LASIK, previously PRK, is much more sensitive to produce haze. So this is a previously touched cornea, and the keratocytes are already in another form of excitation. So the possibility of haze is very high if you do PRK without mitomycin C. I've been using this protocol now for more than, I started in 2012, and it's going very well. But on the other hand, I saw some cases of PRK without using mitomycin C after corneal cross-linking, and the haze is very significant. So it can degrade the vision by that. And second, if you are not accustomed with the or not having a machine of a wavefront guided technology. Nowadays, you can have many refined ablation profiles that can address the same problem. For example, I heard a nice talk from Arthur Cumming about using a Contura vision correction in a regular cornea, and he has his own recipe, a bit complicated, but still we can learn from him. I mean, every single platform can do this. Another platforms who are using Schwind can use corneal wavefront, and nowadays Schwind is providing a very nice high order aberration, high resolution aberrometers, which is Paramis, and it has more the feature of ablating the higher order aberration selectively. So you can select only the coma to save your tissue. So I'm not sticking to a single ablation profile, but I'm a little bit against doing topo guided ablation profile because, you know, the idea is to regularize the whole cornea. So you eat a lot of tissue, and this is exactly as you're using a sledgehammer to kill an ant. So you need a finer ablation profile and a less eating of the tissue, taking into consideration that these cornea are already thin, and you want to save or spare a lot of your corneal tissue.
Thank you. I think Dr. Ala is ready. Thank you.
Yeah, thank you. Thank you, Khaled, thanks to the Jordanian Ophthalmic Society for putting this meeting together. It's really a great meeting, very interesting, very informative. We had very nice presentations so far. I'm going to stop my video so the sound might be better. In this presentation, I'm going to share with you my experience in using phakic intraocular lenses in patients with keratoconus. These are my financial disclosures. I'm consultant to Star Surgical, who is manufacturing the ICL. Today, and after many decades of using phakic intraocular lenses, these are the phakic lenses that are still in common use. The ICL, which has a toric model, the Artiflex, and the Artisan. So these are the phakic lenses that I used with keratoconus over the last 20 years. Nowadays, I'm using, and for the last 15 years, I'm exclusively using the ICL for many reasons that are beyond the scope of this presentation. But whatever is true for the ICL is also true for any kind of phakic intraocular lens that have a toric model. We all know, and I don't need to highlight this, that phakic intraocular lenses are not treating keratoconus. They are not stabilizing the cone, are not improving the irregular astigmatism that is associated with keratoconus. So in order to make benefit of this phakic intraocular lenses in patients with keratoconus, you have to keep in mind that you need to use them on patients with stable keratoconus or stabilized keratoconus, whether you're using cross-linking and or intracorneal ring segments, and also after doing a corneal graft, especially DALK, because it has a better epithelial cell count. So most of the cases where you do DALK, you can do phakic lenses after you remove the sutures. So in this presentation, I really want to stress on the patient selection, because this is the key to success. The technical procedure is very easy. Most of us are using phakic lenses. Technique is very simple, very easy. Calculation is not very different, regular myopic or myopic astigmatism. But the patient selection is the key to success. So we need to have patients with documented stability. And when I say stability, I mean topographic stability for at least a couple of years, manifest refraction stability, especially the astigmatism, and also the distant visual acuity should be stable for at least a couple of years. This is stability. Now, the other and maybe more important or equally important is the quality of vision. the patient must have an acceptable quality of vision. I wouldn't say a great quality of vision or a perfect quality of vision, but an acceptable quality of vision for this patient. You can objectively measure the quality of vision using many tools like contrast sensitivity, modulation transfer function, or high order aberrations or point spread function, but you have always to rely on the subjective quality of vision. The patient should be using his own correction, his own glasses, and he should be happy with these glasses, and he should know that the phakic intraocular lens is going to give him the same vision as he is getting with his own glasses. So this is very important to spend some time with the patients explaining to him that you are not treating keratoconus, you are treating the ametropia that is associated with the keratoconus. Of course, the other regular selection criteria for phakic lenses in terms of anterior chamber depth, endothelial cell count, and so on, this has to be definitely respected. This is the decision tree I'm using for the last 15 years now and keep improving every year with very good results. It depends mainly on the subjective quality of vision. So you have to, first question to the patient, do you have an acceptable corrected distant visual quality, yes or no? And you might spend a few minutes here with the patient explaining to him what is an acceptable quality of vision. It's not only the quantity of vision, it's not only the visual acuity. Patient might be seeing 20/30 or 20/25 with a terrible quality of vision. So now if the patient has an acceptable distant corrected visual quality, the second question is stability. You have to have a documented stability for at least a couple of years. Now, if you have this stability, as we mentioned before, topography, refraction, distant corrected vision, then this patient is a good candidate for a phakic intraocular lens. If he has a low cylinder, less than 1 diopter, then if a spheric lens is okay. Otherwise, a toric lens can be used. Now, if the patient has a progressive keratoconus, then cross-linking is, of course, indicated, and then wait for the stability, and then do your ICL after you document the stability again. On the other side, if the patient has an uncorrected visual acuity, a corrected visual acuity that is not acceptable, then you try RGP with the scleral lens, now giving very good results. If the patient is tolerant, which is very uncommon in our region in the Middle East, then you can do cross-linking and keep the patient with his contact lens. Or if he's tolerant to the contact lens or with an unacceptable visual acuity, then most of these patients will go to DALC. Before going to DALC, in some cases, when the patients are not ready for DALC for any reason, I can use intracorneal ring segments or cross-linking with PRK, and this is my little indication for these procedures. Otherwise, go straight forward for DALC, and then after we remove the sutures 1 year after the procedure, wait for stabilization, and then the patient is candidate again for a phakic intraocular lens. So the indications for phakic intraocular lens in keratoconus are patient with acceptable distant visual acuity, stable keratoconus, or after stabilization, or after DALC. Now, let's spend a few minutes here emphasizing the concept of the quality of vision. And the thing that I found very helpful in my practice over more than 15 years with ICL in keratoconus patients is the looking at MTF, the modulation transfer function, which is an objective way and much easier way to measure the contrast sensitivity. The modulation transfer function here of the total eye, of the entire eye, the ocular MTF, as opposed to corneal MTF. Because with the corneal MTF, you're not including the back surface of the cornea. So you look at the modulation transfer function of the whole eye, of the entire eye. Here shown in pink, it is a very good MTF. Although the patient has a moderate to advanced keratoconus, and this patient has stable cornea for 5 years, between 13 and 18, with the same cornea, the same MTF, then this patient is a very good candidate for phakic intraocular lens, though he has a keratoconus. Now, these are 3 different examples of 3 different patients, all of them correct to 2020 or 2025 with the glasses. First patient has a very good MTF, as you see on the right-hand side, keratoconus, coma, corrects to 2020, very good visual acuity. So this patient is a good candidate for ICL. The second patient corrects to 2025 with an acceptable quality of vision. MTF is still good, more than 40%. This patient is again a good candidate. The third patient who also corrects to 2025, but he has a very low MTF, very poor MTF. If you insert a phakic lens in this patient, he will not be happy. So this patient is not a good candidate for phakic lenses. Another way to look at the MTF using the eye trace, you can, and it gives you here this little box, which is very helpful. If you have the MTF below 40%, then this is not a good candidate for ICL. The other eye of the same patient had an MTF that is higher than 40%, it's 57%, and this patient is a good candidate for ICL. So you have to look at the quality of vision objectively and subjectively. If both agree and you can confirm that this patient has a good quality of vision, and you can do your ICL and you can ensure a good outcome. This is an example of a preoperative patient, and you can see here the topography shows kind of advanced keratoconus with high corneal astigmatism, and you see the internal astigmatism is very low. The corneal astigmatism is 2.6. I put a toric ICL in this patient, and this is his map after 1 year after ICL, and you can see that the internal astigmatism is now 2.29. This is the internal toricity of the ICL, and on the opposite, on the orthogonal median, the total astigmatism for these patients went on from -2.7 to 0.25. So this patient is extremely happy after surgery. And of course, you can correct any myopia that is coexisting. Here he was -5.7, -2.5, and after surgery he's almost plano, and this patient is over the moon, though he still has his keratoconus because he has a good quality of vision. Now, cross-linking had been extensively mentioned in the previous talk, so I'm going to share with you this case, which is very obvious. It shows my point very clearly. This patient had, I saw him in 2012 with the keratoconus. He did a cross-linking in 2012, and then 1 year later, the cornea is flatter, the refraction is +1 now. 1 year later, 2 years after cross-linking, still progressive flattening. That his objective refraction goes to +2. 3 years after the surgery, more flattening. 4 years, 5 years after the surgery, more flattening, and he's now +5. Then 6 years and 7 years, he keeps on flattening. Now, imagine if this patient had a refractive procedure simultaneously, or even 1 year after cross-linking, or 2 years after cross-linking. He might be happy for some time, and then later on, down the road, with the years, the effect of cross-linking is still going on, and this patient will be very high hypermetropic in few years and very unhappy. So that's why I'm totally against doing any kind of surgery simultaneously with cross-linking. Even sequentially, you have to wait sometimes more than 1 year to ensure stability. And if the cornea is not stable, you should not go for any kind of refractive surgery. A case with the PRK and cross-linking simultaneously done on the same day. After 1 year, the patient is very happy. Cornea improved much, but 8 years down the road, the cornea is too flat. It's because of the cross-linking, it is because of the PRK, or because of the combination, you cannot tell. So in my hands, doing simultaneous cross-linking and eczema ablation was never a good idea. Keep in mind that in cross-linking, in 80% of the cases, you have stability of the cornea. In 2 to 3%, you have failure and the cornea progress. But in around 80% of the patients, you have progressive flattening that does not stop for at least 5, 6, or 7, or 8 years. And these patients become very unhappy if you do a cross-linking with any kind of refractive surgery simultaneously. Now, if we look at the ICL calculation, like regular calculation, not going to stop a lot here. Access element is very important, and now it's very easy with the digital systems. This is a group of patients on which we did ICL after either with stable keratoconus or after cross-linking or after intracorneal rings, and the results are extremely good. Patients are very happy. They gain their uncorrected vision improved dramatically. Their correct visual acuity improves significantly because you are inserting a minus lens that leads to magnification of the retinal image. The refractive outcome after ICL in keratoconus is not as good as in inversion eyes, in compound myopic astigmatism, simply because it's not easy to reach the end point of refraction in keratoconus patients. That's why you need to spend a lot of time. I do cycloplegic refraction. I prescribe the correction for the patients. I let him use it for at least a couple of months. And then only if he is happy with the quality of vision, I proceed with the ICL. MTF over time in 30 eyes who had cross-linking, who had ICL in keratoconus, and it's kind of stable, so there is no improvement in the quality of vision, but also there is no worsening of the quality of vision. So if the patient starts with an acceptable quality of vision, he will end and maintain in acceptable quality of vision. Now I'm going to share with you quickly a couple of cases. Before, this is 2 years after cross-linking, and then he had an ICL here. You see his refraction goes down from -15 to almost plano, and he maintains the quality of vision. Another case with advanced keratoconus, unacceptable distant visual acuity, though he is high myopic, but ICL will not help in this case. So we did DULC on this patient, remove the switch after 1 year, and then ICL later on, and correct his astigmatism with the ICL, with the toric ICL, and the patient and almost plano with very good vision and very good quality of vision. A moderate keratoconus, not acceptable visual acuity. These are the only cases where I use intracorneal ring segments, trying to improve a little bit the shape of the cornea. Now, if the patient has a good and acceptable quality of vision after the intracorneal ring, I go for an ICL. If not, then I go for DULC immediately. The last case I'm going to show you an advanced keratoconus, very advanced keratoconus, very high myopia, the 3 diopters of cylinder, but the patient is happy with his quality of vision. And this is a straightforward case. You can do a toric ICL, and the patient will be extremely happy after the surgery. Internal toricity is 3 diopters on the orthogonal meridian from corneal astigmatism. The total astigmatism is almost 0. Then the patient has a very good refractive outcome and very good quality of vision in this case. So the take-home message is that phakic intraocular lenses, especially the toric phakic lenses, are very effective, predictable, and safe for the correction of the refractive errors that are associated with keratoconus. But the patient must have a stable cornea or stabilized after cross-linking, and must have a good quality of vision to start with. And if you follow this little, very simple rules in patient selection, your patients will be extremely happy. So the key for success is to proper documentation of stability, to have an acceptable preoperative quality of vision, and you can measure this objectively with the MTF curve, with the point rate function, or high order aberrations. And preoperative cycloplegic refraction is very important. And you have to spend time counseling patients before the surgery to explain to him that this is not a treatment of keratoconus, but this is a treatment of the refractive error that is associated with keratoconus. And I thank you for your attention.
Thank you very much, Dr. Ala. Very impressive, really. And I really agree with you about the sequential and not doing a simultaneous PRK and cross-linking, because we face the same problem and we saw the same patients that we just mentioned and showed. Thank you very much for this very impressive talk. Next speaker is Dr. Sameh Hamada. Please, Dr. Ala, if you stop sharing your screen.
Yes, I'll do it now.
Thank you very much. Please, Dr. Samer.
Okay, good afternoon. Can you hear me well?
Yes, very clear.
Good, excellent. Right, well, thank you, Dr. Khalid. Thank you, Jordanian Ophthalmology Society, Middle East Hospital, and Light for Sight for inviting me to talk. I appreciate it's a bit too late, so I'll try to be like sharp to points and get the message as much quickly as possible. So you've been kindly asking me to talk about pediatric keratoplasty. What I thought is better to talk about how to avoid pediatric keratoplasty, because I think that's more relevant to all of us, both whether we practice in highly specialized clinics or just standard clinics. So what I want to start to say, you heard a lot of things earlier in this seminar, that the K-Max, we're still building all our planning on management and diagnosis on the K-Max. We're waiting until there is documented progression of keratoconus. And also we don't want to intervene until the patient lost vision. That's not really ideal. And this is really different what we do in medicine. So for example, if you have a patient with high blood sugar, high cholesterol, you don't wait till they have a stroke or they lose their retina before you start them on treatment. So why we do the same, we don't do the same keratoconus the same way. We should really treat early and detect early. So that is not acceptable. Especially as you can see here, I said in pediatric keratoconus management, there's no way you can wait because the disease is so aggressive and progressive. And let me share this thought with you. So you know, this is show you the keratoconus progression from no keratoconus to severe keratoconus. It is a reversible process. Keratoplasty possibly able to reverse some of the vision, but you know that is not the ideal option because a lot of patients, majority of them, they still need optical correction. They still need contact lenses. They have a lot of issues with the graft. You're not going to restore a normal cornea, not even a mild keratoconus status. While if you do go for other things like different modalities, crosslink, for example, the earlier treatment, the better. You can reverse those patients back to the mild, or they keep them in which stage they are in. So you can see keratoplasty maybe make a big difference to those severe, moderate cases, but not really for mild. So we don't want to get the patient to get to that end. When it comes to the pediatric group, look at this results from the SELECT study. So when they compare the children and adult groups, you can see the majority of children have already advanced disease. So almost 30% are stage 4 keratoconus at the time of diagnosis. That to show you how late. 42% showing the signs at this time of diagnosis. And look at the K-Max. Already those patients have advanced keratoconus, so they're really at borderline stage where they might benefit from a cross-linking, and mostly they'll need the keratoplasty. So really our mission here to change those figures. And if you're asking, so how likely progress the keratoconus progress in children, it's obvious from all the studies which you've seen before, different from adults. While adults might progress 14 to 30% over 2 to 3 years, children will progress almost everyone will progress over 3 years. And this is Hafizi paper. Farhad left, but his paper was amazing because he showed that this is the less severe eye. This is a second eye, contralateral eye. They cross-link one eye and they look at the other eye as observation eye. And those eyes, which meant to have a less severe condition, they progress over 3 years. That tells you how aggressive the disease. Think about, so how can we prevent the progression? Really difficult and challenging. Children will not tell you about their vision. They have a strong accommodation, smaller refractive error up to 4 or 5 diopters. They accommodate and they overcome that easily. They don't complain. So it's difficult to tell. Luckily, there are still old tools. They still work very well, like using your retinoscope to look at the scissoring, look at the oil drop, the sign, refraction, very important. Those are really basic. Only appreciate the value of those when you're dealing with the children, because you can diagnose keratoconus based on very simple measurement and measuring vision and refraction. Topography. Now, there is a lot of thought about, okay, does topography make any difference? Can we rely on topography to diagnose keratoconus in children? I would say you can do topography from age 6, but beware that it's not always reliable in children because they might behave differently. Their cooperation might not be good, poor fixation, etc. And more important, a lot of children with keratoconus, especially younger ones, they might have other conditions, such as this case is a VKC. If you think about the cornea topography in this case, it's going to look really abnormal because remember, epithelium does swell and does not swell evenly throughout. We heard a lot about epithelium mapping. If you do epithelium mapping for cases like this one, you find there's variation. Part of the cornea epithelium is thick, part is thin. But once they treat it and the inflammation gone, the epithelium mapping will be improved. So be careful when you do topography in children, especially OST. Now, are there any specific topographical signs? I want you to think a little bit different here. This is not adult keratoconus, this is more children. And looking at tens of topography in the past, and I realized that actually you don't always see the same manifestation or signs on the topography. For example, the last thing you see is basically the elevation on the anterior and posterior maps, opposite what people think in adult keratoconus. Thickness, yes, change, but the most prominent, the most likely you'll see is some curvature map. So the anterior sagittal curvature will show you there is a bow tie, king bow tie, snowman, and all these changes. And yes, Bellin-Ambrosia can be different, but IHD and ISV are usually in yellow or red. It tells you there is some irregularity in this cornea. And this is the second eye for the same patient. You can see less problem with the elevation maps, but obviously here there's a bit thinning on the cornea, but obvious the asymmetric bow tie. And the same story, IHD there is high. So when we talk about keratoconus progression in children, think about refraction and vision. This is your main tools to monitor the children. Topography, really useful and can help you, but you have to read it with cautious. It's especially you look at the refractive map. You probably heard about Bellin ABCD keratoconic staging. Very useful, but in children, I think I will take mainly the A and D component, that the visual acuity as in D and the anterior radius of curvature. I don't think B and C will show so well, especially in younger keratoconus children. And then you think about risk analysis. Not all children with keratoconus progress so badly. Those with the comorbidities, atopy, course of inflammation, they're the ones that do badly and they progress quicker than the others. Now, this is again from my observation, looking at tens of cases of children with keratoconus. And you can see in this graph, normally you don't see keratoconus before age 4, but that time you see more and more cases. There is a peak here at around age 11, 12, that's the puberty age. And then another peak of keratoconus, the blue line, at around 18, 19. This is when those children grown up now, they're looking for jobs, they have their vision tested, they're looking for driving license, they're joining the army, the police forces, they need their vision checked, and then suddenly if they found they have the condition. So I think the true peak is around puberty age, not necessarily around 18, 19. 18, 19 is artificial peak, it's just because they're looking for profession and they change in career. Now, that can be explained by the rigidity of the cornea. We know the cornea, always textbook tell you it's so elastic, the eye so elastic in child, but when the cornea become more rigid at age 4 and above, then the keratoconus start to show itself. But I think they're born with it, it's just when they show it. And that brings us to, so what shall I do to screen those children for a keratoconus? Really tough. And I don't think that's a complete answer, but that's something from my experience dealing with a lot of children with keratoconus. So the children normally above age 4, as I said, below 4, I haven't seen a case with diagnosed with, I'm convinced it's a keratoconus. Astigmatism, very important. Is the astigmatism high? Is it irregular? Do you have irregular astigmatism and asymmetrical astigmatism between the two eyes? Very important. Does the vision correct well with the glass or not? If it's not, that tells you why. Could be this is very highly irregular cornea. Is there a family history of keratoconus? Is there atopy risk factors? Does a child rub their eyes, their habits? Are there other syndromes like those children with a syndromatic eye rubbing all the time? So these things tell you that those children need to be observed carefully because they might develop keratoconus at some stage. And just to see the big problem, this is old data, but it's very valid data. And I don't think it changed beyond 2010 and search for the global blindness data from WHO. You can see corneal scarring for various reasons, including keratoconus, responds for 25% of the cases in the Middle East. This is one of the highest in the world. If you look around for other countries, it's our other part of the continent, we have the highest in the Middle East. And that's avoidable. This is 190,000 children estimated blind from cornea. So we are really late to diagnose, pick up those cases. And what we need is to activate a screening program somewhere we can pick up those children before they're too far. Okay, so the second question, so who and when to treat? Obviously, we like to make sure that actually keratoconus is confirmed. So we have confidence this child does have a keratoconus. Then you ask yourself, shall I wait for progression? I don't think anyone with a good experience with the pediatric cross-linking will wait for those children. The majority will agree that actually, if you are sure, go ahead and treat. And especially those one with a high risk, because sometimes the parents are a bit not sure, it's a new treatment, children, they be hesitant. So you have to value everything and assess whether there is a very high risk. And again, parents' involvement. For example, if you got a child, the parents are then not really well educated, you don't think they're gonna follow on well, I would cross-link that child without just wasting time, because by the time you do follow-ups, they might disappear, don't see the child, you waste a chance. And we know that keratoconus is multifactorial disease. And while some of the factors are, you can't modify it, our DNA, our genes, our hormones, you can't change those. You can modify some other factors. You can ask them to stop rubbing, and you can deal with some comorbidities. Remember, you are treating a patient is not just the eye. So they might have an allergy, VKC. Those patients can benefit from systemic treatment, from immune therapy. So I often send them to immunologists or dermatologists. They deal with it, and they're much better. They stop eye rubbing. Because it's a bit harsh to tell the child, don't rub your eyes. I mean, even adults, they will do it. You have to help them to develop a habit. Now, my management strategies, and this is, I apply for adults and children, but in children, there are things that you focus more on. So it's a very simple, we forget about diet and supplement. If you think about the generation now, they're going into very crazy diet. The vegan diet now, for example, is very popular. There is a lot of antioxidant in the, we need that to stop the damage to the cornea from free radicals. Otherwise, you allow the disease to progress. So simple term, I would say, a healthy cornea able to resist changes more than unhealthy cornea that has a lot of damage from inflammation and from free radicals. Now, developing habits. This child, they might need to change in their environment, their room, where they were the sun, the habits, where the way they live. So many. You have to look at dig deep in the lifestyle and work with the parents how you can change the child habit. They stop eye rubbing and they have less inflammation. So control inflammation. Yes, we said atopy. 53% of those children with keratoconus children have atopy, so atopic. So that is, they will rub their eyes. They have all this all the time. The way to control inflammation is really simple. If you see, this is a very nice diagram from this German group, but it's very simple. Controlling inflammation at various levels, from steroids to using the omega-3. You're working on arachidonic acid, to using cyclosporins. Now we have a leafy grass, tacrolimus, cyclosporins. All these elements help you to control the inflammation. And remember the active phase and the long phase. Now people say you give cyclosporin for children with the keratoconus. Well, yes, because not everyone, obviously, those with inflammatory component, because I strongly believe there is a big role for inflammation in progression of keratoconus. Now, how about cross-linking? I don't think we disagree on that, but don't delay it. It has to be done at times of diagnosis. The standard now, EP-on standard or accelerated, and we have a very good result of accelerated. And we have we're going to publish a series about children younger than 10 who are cross-linked. Obviously, the hope for future is to have the EP-on cross-linking, and obviously we don't know much about the long-term follow-up. So let's just touch on pediatric keratoplasty. I hope we don't get to that stage, but unfortunately, we see those children from time to time. And they end up with you because they have very advanced cone or the cornea scarring. It is challenging because remember, the thing that worries me the most is about poor prognosis, right? These children not necessarily do well. Also, the majority do very well with a very good care. A lot of them end up, especially if it's unilateral condition and if they're younger than 12, amblyopia, the rejection and the glaucoma risk and all that is still there. Even if you're doing DALK, you still see a lot of glaucoma cases in children. So pediatric keratoplasty, I know it's super specialized service. And that's why I didn't want to talk about it because, I mean, in the UK, we are 2 or 3 surgeons doing all these pediatric keratoplasties. So it's not something common, but we're hoping that we're doing less. And I'm seeing less actually because we're doing a lot of cross-linking. When we're doing a graft now, we are lucky to have the advantage of the femtolaser because now we can do femto-DALK and femto-SALK, which is very, very useful and very good for pediatric cases. Remember patient and family factors and the post-op visual rehabilitation is not enough to do a good job, good surgery. Restoring the vision for those children is really extremely important. And this is, again, it's a hard keratoplasty for various reasons. Not only just the age, it's the comorbidities which are often there. So just to touch on how can I, if I have end up doing keratoplasty, how do I optimize the outcomes? And really important is inflammation. I keep repeating inflammation, inflammation. If they have inflammation, you need to work around it, which we showed earlier. Cornea vessels, remember, fine needle diathermy for those established vessels and anti-VEGF for those new vessels, right? And this works really well. You want to prepare these eyes before you proceed with anti-keratoplasty. This is an example of a child. 2 grafts failed. You can see he got ichthyosis. All his skin is like that. There's no way you can stop the exposure. You can't do skin graft from him. It's a bit difficult. So what we came up with is just doing fillers, just the cosmetic fillers, pretarsal injections, help to do like a natural, not natural, like induced tissue expansion. And for the first time, the child can close their eyes fully. That helped for this graft. You can see here, since 2013 until today, he's still well because we managed to protect this eye. So just to show you that a few small things can help you to optimize your outcomes. So I want to finish by saying really the key 3 things here on those pediatric cases with keratoconus to detect early. Have a low threshold to think, does this child have a keratoconus? An early treatment, and not only I'm talking about early cross-linking, early treating of inflammation, the risk factors, right? Because you delay the progress a lot. And you treat comorbidities. A lot of them, as you said, they have this inflammatory condition on the surface. If we do surgery, obviously, we go for lamellar keratoplasty because it gives you the best outcomes. And don't forget about visual rehabilitation on those children. I would stop here, and I hope I've been on time. Thank you very much.
Thank you, Dr. Samer. Very impressive and very nice presentation. I think we can have a window for some questions. Dr. Miguel is again with us. Thank you very much for your time and for the talks. Dr. Samer, what is the youngest child that you did the cross-linking for him?
I think we have at least 1 child who's 5, and 6 and above, we have many. So we remember one thing, I don't think I've mentioned it, is a family history. So a lot of times you find a strong family history, and we pick up those children by asking, okay, can you bring the siblings? And then you find more and more cases. And that's how you diagnose the very early ones. And very important, educating your team, your community, your optometrist. I mean, since I started, I've done a lot of educational programs for the optometrists in the region. And suddenly we have all these children were just treated for glasses in the practices in community. Now they're coming to hospital and we picked up. I mean, to be honest, I mean, Allah will know. And in Saudi Arabia, probably you done a big study there where you found crazy number. If I remember right, 1 in 50 of patients walking through the door, they have a keratoconus. And those advanced cases, people think that there's no way the cornea will suddenly have a Kmax, massive Kmax 59 and 60 overnight. This is a pediatric childhood disease that just develops slowly to reach that stage.
May I ask a question, Samer? I enjoyed very much your talk because I think the question and the problem of the pediatric corneal cross-linking is there in the Middle East. So first of all, you're practicing in England. All of them are from Middle Eastern genes, or you find this in Western community population or Caucasians.
Mohammed, very good question. To be honest, interesting that where I practice Southeast England, we don't have too much mixed ethnicity, if you like. So a lot of our Caucasian, right? Very few Asian, I would say. If you go to Birmingham North, you find more. But I can tell you that we see it in Caucasian is common the same way, but maybe not as common as if you go to Birmingham to North England. Obviously, you see more cases. My estimation that in the South, in Caucasian, around 1 in 2,000, while if you go to other ethnicity, you probably talk about 1 in 300 or so.
Did you recross-link some of them? Because in Egypt, I found some of my children still rubbing their eyes and they regained again. I have beautiful examples because I led a study on my pediatric corneal cross-linking cases, and I had to recross-linking a couple of them.
Yeah, it's interesting you ask this question because the one I remember cross-linking are from the Middle East. I don't remember I cross-linked some Caucasian eyes.
Yes, of course.
Yeah,
I think so. All of them are
children.
maybe
I'll talk about,
Mediterranean basin origin. I mean, from the south of Mediterranean more than the north, but the majority of them are maybe because of the inflammation and so on.
Yeah, true.
I think in my experience, I recross-linked 3 pediatric patients after 6-7 years. The things are two. The first one is to cure the inflammation, and the second is usually the collagen turnover is about 6 to 7 years. So we have to look closely at the patient in after 6-7 years, especially if you cross-link it at 10 or 8 years old.
Actually, the patients that I had to recross-link again, that was in the next year. I mean, I did a recross-linking because of the progression after the first one. And
always EP off moment?
Yes, always EP off and always Dresden, classical Dresden one, especially in the children. In the children, I believe you have to give them the maximum, 3/30.
Yes, yes, I totally agree.
You have to exhaust to the maximum because the disease in children is so aggressive. And in spite of that, they kept on progression of their astigmatism and even the Kmax. So I had to recross-link them again.
I agree with you. I think it's very interesting that they come back for cross-linking very soon, which is that's my experience. Also, the papers say 3 years plus they start to show regression or progression. But my experience, like you, Mohammed, just next year they come and they're still progressing. Yeah.
No, just that my question is because is it a failure of cross-linking or it is an aggression of the disease? And I think it's more aggression of the disease.
Yeah.
The child is keeping on rubbing his eye with a lot of inflammation, and the inflammatory mediators is keeping on digesting the collagen and progressing the disease.
Yeah. Can I say something? I think a couple of people actually asked a question on the QA here, and I'm not sure what's your protocol. It's a very simple thing. It's just about how likely the eye dry out throughout the treatment, and do you use speculum or not? I mean, I tell you, we have 2 settings. We have the outpatient settings where we do cross-linking, and we have theaters, right? And we have a brand new theaters. They call it singing and dancing because it's so luxurious and so good. But the ventilation system, air conditioning is crazy, right? It's I can't remember what they call it, but we noticed that actually when we put the speculum, we start to see we're getting really too much cross-linked, right? A lot of haze afterwards. And I said, what's going on? We start to measure thickness and found this cornea thin throughout the treatment. That half an hour, the cornea, it's crazy numbers, 100 micron, 120, 130. It's just unbelievable. And that's why I removed the speculum in theater and I put like something above to cover to stop the air flowing.
But you can hydrate your cornea during the corneal cross-linking, even with an antibiotic eye drops.
Yeah, it's unbelievable. Yes, I know what you mean. Yes, yeah.
I have to answer one of the questions that was on the screen. Very interesting one, but then it goes away. It went away without answering it. It was, can we able to do a post or a sequential PRK in already cross-linked eyes after and with an intracorneal ring segment in them? And my opinion is no, because you can't read well the cornea with an intracorneal ring segment inside them by any means. I mean, it's very difficult to refract them. It's very difficult to acquire a reliable map, whether it is a topographical map or a wavefront map. So it's very difficult to actually to do PRK and to have a good results on an eye with already cross-linked and having an intracorneal ring segment in it. This is my question. I don't know if you want to try something like this, but it's difficult.
I would like to comment, to have some comments of a question of a sequential or at the same time PRK or PTK. So my question to you is, I saw a lot of excessive flattening in your patient, in which you complained about the excessive flattening. What kind of a cross-linking do you use? Which energy? Because I saw this kind of a flattening just in the Dresden protocol patient that I abandoned from 3-4 years ago.
These were the cases of Dr. Ala Danassori.
Dr. Ala, what kind of cross-linking did you use for in that case of excessive flattening? Can you hear me?
I'm mute. So the question is, what kind of cross-linking did I use in?
Yes, in the case of excessive flattening.
That was accelerated cross-linking. Accelerated 10 minutes.
So 10 milliwatt?
10 minutes.
10 minutes, okay. No, my question is why I do most of time cross-linking and laser at the same time. Really, the first target of me is not refraction. So to me, it's just to remove epithelium and doing just a little ablation. So literally never more than 30, 35 is rare more than this. The other question is I never had an AIDS just because if you cross-linking after the ablation, you kill the keratocyte. So do you do not have the actor of AIDS? So that is the other question. And the other question is if I end up with a refraction in which I'm not satisfied, I go on intracorneal lens, like Dr. Ala showed beautiful to us. That's my reason. And the other reason is that I do just one procedure, and the patient usually is not so prone to do another procedure after 1 or 2 years. More than this, okay, I have some flattening in the years, and I take into account this. So that's the reason why I go very, very mild on excimer ablation. If you look at Athens protocol, you will look ablation more than 50 micron excessive, and that's the point for me. That's a fault.
With wavefront, can I ask, with wavefront, how deep can you go? Do you limit yourself? How much?
Yes, absolutely.
No, Miguel, I know you follow the 50 micron rule. Is that right?
Yes, but 50 micron is the exception. Usually the average is 20-25 micron.
Yeah.
If I go more, I just selectively remove the epithelium. That was what I show you in a lot of my cases.
Yeah.
So sometimes I'm really not aggressive. That's the question.
I'm asking Dr. Muhammad Shafi, in your cases, what's your average thinning of the cornea?
First of all, I never do now Athens protocol because I'm totally
no, I mean with your front, with your describe, yeah.
The wavefront is I showed the guidelines that I am sticking to it. The maximum is 15% of the central corneal thickness, and then you should leave your cornea more than 400 microns at the end.
Always.
If your cornea does not allow the thickness, I don't go never for a PRK.
400 with epithelium, so.
Yeah. With epithelium at the end.
Okay.
Taking into consideration that the epithelium could be 50.
But does that mean you can go more than 50 micron in your case?
Yes, sometimes, because I have many nice cases with 500 520 or 530 after corneal cross-linking and with some refractive error. So I can go more than 50 microns.
Yeah.
Because in those cases, if you see the demarcation line, and I have beautiful examples, you have more than 350 microns of corneal stiffness. If you remove like 70 microns of them, you still safe.
Yeah. Someone asked you if you cross-link again when you come after 1 year to do the treatment. I assume not. Is that right?
No, I don't do, but I keep an eye on those patients, and usually I ask my patients to do a 6 monthly pentacam for the first couple of years, and then every 1 year. And then, of course, the best parameter, and I like very much your input in Simon in this, the most important parameter for me is the loss of the best corrected visual acuity. This is the very first indication that of the progression of the keratoconus, and the second for me is progression or increase in coma, because I do for them with front data acquisition campaign also.
Ala, can I ask you just about the ICL? What is your I don't want to ask you about the happy patient, because I'm sure there are thousands of them. I want you to ask about the unhappy patient with keratoconus patient with ICL. What were the reasons why they were unhappy, for example? Do you remember a couple of cases, for example? Maybe none.
Of course, yeah. Of course, I have some unhappy patients, and those unhappy patients I usually do with the expectation. So if you don't spend enough time with the patient explaining to him before the surgery and to set his expectation, you will have unhappy patients. The one I really remember, because he gave me a hard time, was a patient with the keratoconus, moderate keratoconus. He was happy with his spectacle correction. Then I did the surgery, and he had his corrected distant visual acuity after the surgery was kind of 1 line less than his spectacle corrected vision. Looking at his axis and alignment, I found lens, the ICL toricity is off axis compared to the corneal astigmatism. So I went back and repositioned the lens to where I thought it should be. The patient even got worse. So I had to go again and do another repositioning and align the axis of the astigmatism with the refractive axis. So from this patient, I learned the hard way that you have to go with the refractive cylinder rather than the corneal astigmatism.
Okay.
I agree totally with Ala, because you have to verify the subjective axis very much. And I don't know if you agree with me that some of these patients have such an irregular cornea, so when you twist the frame or the axis, they always say that they have such kind of unknowing shadow. If the patient is insisting of seeing this shadow and he's totally annoyed all the time, and he's not accepting the best corrected glasses, so don't fix for him or don't implant for him a toric ICL. He will give you very hard time, because from the start, the cornea is too much irregular and he's seeing always this kind of shadow. So I think it's much better for him to go for a hard contact lens or something of this sort.
You know, Muhammad, yes, I do agree. And I would like to mention one hint that I learned over the years. The MTF is very helpful. You have to look at the high order MTF and the low order MTF. And the difference between the low order MTF and the high order MTF is the amount of correction that the ICL can give you. If your low order MTF is close to the high order MTF, then this patient will not be happy. If there is a difference, then there is room for this patient to improve, and this patient will be very happy. So the MTF, for me, it is a very important indicator of whether this patient be happy or not.
Yeah.
Nice trick.
Dr. Mohammed, Dr. Ala, can I ask also, do you use the toric IOL in patients with keratoconus who developed cataract?
Can you say it again, please?
Very, very good question.
Toric IOL in patients who has cataract and keratoconus.
So you mean phaco with toric IOL?
Phaco with the toric IOL.
Yes. If a patient has cataract and he has a keratoconus, and he has a regular astigmatism, then you can do toric IOL. But if the astigmatism is too
We lost your voice, Dr. Ala.
irregular, and in this, did you lose me?
Yes, we lost your voice for seconds.
I was saying in this case, you need to look at the corneal MTF and not the ocular MTF. If the patient has a good corneal surface, the irregularity are not that big, then you can do a toric IOL, because the toric IOL will correct the regular component of the astigmatism, but not the irregular one.
Yeah.
Yes, I agree totally. I have in my practice 3 patients who came with clear cornea, with clear crystalline lens, I'm sorry, but with high sphere and cylinder, and at the same time they had the cornea stable because of their age. We can't, of course, we can't implant a toric ICL after 45 years because the lens is sick. In those cases, if you are able to take the best corrected visual acuity, the sphere and cylinder again, before the development of the cataract, you can go and fix a toric IOL depending on the subjective axis again, and they become happy because they are used to this subjective axis in these glasses.
Yeah, can I share my experience? I mean, yes, I do that sometimes, but my general trend, whether they have difficult to refract eyes because they have irregular corneas, or they have a keratoplasty cornea graft, I tend to do 2 surgeries. So I do the monofocal non-toric IOL first, I refract them, and then I do a toric piggyback lens after that. And I have to say, I have a very good result because I know exactly what refraction I'm working on, and I put that lens, and I'm the best doctor in the world. I'm not, but yes, it works.
By the way, you can do this. You can do the add-on in form of toric ICL also.
Yeah.
Yeah, but
the same. Yes.
Exactly. I have a couple of comments here. I don't see a problem putting an ICL in a patient who is 45 years old if his lens is clear. I've done this many times.
Yeah.
The other comment is the back surface astigmatism. In these patients, there's a lot of astigmatism in the back surface. So if you use a topographer or a tomographer only that gives you the anterior surface, that's not enough.
Yeah. That's the reason. The only thing that we can control is the posterior curvature, Ala. That is the problem. So.
Yeah, but you need to take it in consideration in the IOL calculation.
Yeah.
Yes.
Good.
Dr. Ala, there is a question. I think you answered that question, but I think it's a very good question about the glaucoma in phakic lenses. Do you face to remove an phakic IOL due to glaucoma?
Do I have to remove a phakic lens and do glaucoma?
Due to patient that developed with time glaucoma?
I am doing ICL now for almost 20 years. I did not see a patient who, I did not see any of my patients who developed glaucoma after ICL. I have seen a patient with Urey-Zavaria syndrome where he had surgery somewhere else, and he came to me a few months later with fixed dilated pupil with glaucoma flecken because of the high intraocular pressure on the first day after surgery. But I did not see a patient who developed glaucoma because of ICL. But if a patient develops an off-angle glaucoma, you can just do the glaucoma surgery or give him medication, or you can remove the ICL. So, but I did not see an ICL-induced glaucoma.
Yeah, I think the new version with the hole in the middle, that's obviously make difference for the incidence of glaucoma. And I think one of the problem is because they are young patients, they are steroid responder, 30% steroid responder, at least in our group here in the UK. And so I tell them you'll have my spike of pressure first few weeks after treatment, but then it should settle. So I share with you a lot the same experience. There's no glaucoma here. Okay.
Thank you. I think it's a very interesting talks. We have a very interesting speakers with very
Khalid, we managed to convince 125 people to stay 3 hours and a half.
Yes.
That must be a good sign.
because we have the
Past midnight as well.
It's still more than 100. So
Yeah.
thank you for our audience.
Thank you very much. Thank you, Khalid, for organizing this.
our talk.
Thank you, Khaled.
Yeah.
No, thank you very much for your valuable time, and hope to see you in the near future.
Thank you
Thanks.
very much. Thank you for the nice company and the speakers. I enjoyed it very much.
Thank you, Dr. Muhammad.
Thank you all.
Thank you.
Great talk. Thank you.
Thank you, Samer.
Good evening.
Have a good night.
Simon Amman.
Thank you to all. See you in Amman or in
Yeah.
Egypt. Eh? I'm
Yeah.
waiting for Egypt.
Well, you still need to read that magazine, right?
We're going to visit Khalid and Ala.
Yes. So thank you for all, and keep in
Okay.
touch, guys.
Good night, all.
Thank
Bye-bye.
you.
Good night.
Bye. Bye.
Take care. Thanks.